Good morning, esteemed guests, colleagues, and participants. I am Dr. Utsav Anand Mani, Assistant Professor in Emergency Medicine Department at SGPGIMS. It is my great pleasure to welcome you to this national level webinar on quality in healthcare settings for healthcare workers, organized by Indian Society of Medicine, Lucknow branch in collaboration with Quality Cell Department of Hospital at SGPGIMS. Today marks the beginning of our two-day journey dedicated to enhancing the quality of healthcare through insightful discussions, expert presentations, and interactive sessions. As healthcare professionals, our commitment to excellence is unwavering, and this conference serves as a platform to deepen our understanding and improve our practices. Our agenda for today include a series of sessions led by distinguished speakers who will be sharing their expertise and insights on various critical topics. Overview of healthcare quality by Mr. Abhishek Bera, Green Hospital Concept by Mr. Dr. Jeet Patwari, Patient Safety Goals by Professor Nadira Chaturvedi, Pharmacovigilance in Hospital by Professor Subrajyoti Bhaumek, Care of ICU Patients by Dr. Reducing Medication Errors and Improving Patient Safety, Tirpe, Prevention of Clapsy, Recent Recommendation and Guidelines by Dr. Ashmita Paul, and Patient Safety Goals by Mrs. Gargi Das. We are honored to have esteemed guests with us today, including R. Harshvardhan, Professor V.K. Paliwal, and Dr. Prerna Kapoor. We would like to express our sincerest gratitude to Professor Sanjay Dhiraj for his guidance and support. Their presence underscores the significance of this conference and our collective commitment to improving healthcare quality. Let us use this opportunity to learn, collaborate, and innovate for betterment of our healthcare system. Thank you all for being here, and we look forward to a productive and an inspiring day. Now, I would like to hand over the mic to Mrs. Usha Takari, CNO, to give the welcome address.
Good morning to all and one present here. And Professor Dr. Sanjay Dhiraj, sir, CMS. Welcome you, sir, honorably. Thank you. Professor V.K. Paliwal, sir, MS. I welcome you, sir, happily. Dr. Rajesh Harshvardhan, HOD, Department of Hospital Administration. I welcome you, sir, wholeheartedly. Respected Dr. Prerna Kapoor, General Hospital. I welcome you, ma'am, with open arms. Thank you very much, the organizing team, for this auspicious webinar session on quality in healthcare setting. I extend welcome rainbow to all the speakers and moderators of this national webinar, all the invited guests and delegates for attending this glorious session on quality. Once again, I welcome you all sumptuously. May this national webinar on quality in healthcare settings be a platform for meaningful discussions and the exchange of ideas. Those will further enrich our understanding of quality in healthcare settings. Let us foster an atmosphere of camaraderie and learning throughout these intellectual sessions. Welcome one and all once again. Thank you.
I now request Mrs. Juindat Ghosh to present Mrs. Usha Takri ma'am with a token of gratitude.
Good morning and a warm welcome to the guest of honors, dignified speakers, and all the participants and viewers who have joined us offline and online. The national level webinar on quality in healthcare setting for healthcare workers conducted by Indian Society of Critical Care Medicine, Lucknow branch, in collaboration with Quality Cell Department of Hospital Administration, SGPGIMS.
Quality in healthcare is paramount as it directly affects patient outcomes and overall health system efficiency. It encompasses various dimensions, including safety, effectiveness, patient-centeredness, timeliness, efficiency, and equity in ensuring high-quality care that involves adhering to best practices, evidence-based guidelines, and continuous quality improvement processes. It requires a multidisciplinary approach involving healthcare providers, hospital administrators, and foremost, our patients. Monitoring and evaluation through performance metrics are also crucial for maintaining and enhancing quality.
Now I request our HOD, Hospital Administration, Dr. Rajesh Harshvardhan sir, to offer a brief comment on this occasion.
Good morning to Dr. Sanjay Dhiraj, Prerna ma'am, all the organizers, and the entire range of delegates who have joined us online. I was wondering while going through the schedule that have you left anything to be taken care of? Because you have put the theme as transforming healthcare effectively, economically, ecologically, and efficiently. what's more there to aim for. If you really understand the meaning, the depth, the intent, the purport that these four words carry from the frame of reference of quality along the healthcare spectrum. I would like to begin with the fact that the concept of quality was very much there in the yoga years. I mean, I'll quote a line from Gita, Yoga Karmashu Kaushalam. कर्म की कुशलता का नाम ही योग है. So the karma ki kushalta was actually denoting about the quality in whatever we do. And in modern era, I think it dates back to somewhere 1620. And it picked up when during the time of industrial revolution in the Europe, wherein the mechanized industries, in order to maximize their profit, they tried to look at the finished product as to the product which is going to market. It actually began with the product industry, then it came to service sector. So they started looking at that every product should conform to certain preset benchmark, and they call it quality check, QC, and that was the formal birth of the concept of quality altogether under the arena of the management. And it gradually evolved over the course of next 100 years or so, wherein whenever the product was being sent to market for sale, it was to be examined that does it conform with all the preset standards, then only the product was allowed to go into the market. So it was being done at the level of output. So when one industry began with it, other industries followed this suit, and gradually the concept took over and swept the entire globe, primarily the Europe and other Western countries, and it became a firmly established concept in the industry sector, the manufacturing industries, and then subsequently other dimensions as well, wherein every product was supposed to undergo a quality check. When people did what all they could have done to ensure the quality at the end, at the level of output, then they thought, what next? Then they started looking at why there are some products which are not meeting the quality standards, and they were to be refused, they were pulled back, and they were not being sent to market. Why? So they tried to let us look at the process, how that particular product is being made. So the concept of quality expanded to the process part now. And again, that gave birth to an organization that widely known now was ISO, International Standards Organization, which was primarily conceived, conceptualized, established, commissioned, and sustained to ensure that in industry sector or manufacturing sector, the process pathway must conform to preset standards. Then only the output will be of a desired quality level. So that gave birth to the second segment or second arm of quality journey, wherein they started looking at the process part. But it impacted now, by that time, it impacted the service sector as well. When healthcare deliveries also comes under service sector, banking, insurance, all under service sector. So when the concept of quality during the processing part came, it overspilled to the service sector. But till that point in time, it still didn't reach the healthcare sector. And there were many studies being conducted all over the world in all the premium institutions as to what all ought to be done, must be done to make sure that the process pathway is standardized, and that gave birth to many ISO standards for different service sectors and different service industries. And there came a point in time along the quality journey that there were standards available, I mean, for entire range of product industry or service industry. And people thought, now what? How to augment quality further? Then they started looking at the input level as to let the raw materials be better before they are processed. So that gave rise to the concept of total quality management. So when in an industry, product industry or a service industry, when you look at the entire range of the process, entire range of service delivery or product manufacturing at the level of input, at the level of process, output, then we call it TQM, total quality management. That means quality is being ensured and assured down the entire spectrum, entire process, entire pathway, input, process, and output. So interpolating it into the healthcare industry, if we recruit doctors, then we look at their qualification experience. That's at the level of input. If you design SOPs to deliver, say, for example, ICU care, say, for example, critical care, what is the walkout rate? What is the hospital-acquired infection rate? What is the ADR rate? What is the reinvestigation rate? No, repeat CT scan, readmission rate after surgery. So we design many KPIs, and then we have got at the level of output, mortality rate. We convene mortality meetings. So it was then interpolated to the healthcare industry, and when you try to look at how to design quality parameters, either for the process, either for the input, or the process, or the output, and that gave birth to the TQM, total quality management. But when we are never satisfied. There's no full stop on road to improvement. सुधार की दिशा में पूर्ण विराम कभी नहीं होता. There's no full stop. So we can always improve. So people thought, what next? If we have put a system in place for at input, at process, at output, and we have achieved all these, so what next now? So they thought that let us raise the bar, and that gave the concept of CQI, continuous quality improvement. So, and then a phase came close to 10, 12, 20 years, wherein people started looking at all the entire pathway from the perspective of CQI. Well, that has been the nature of human being per se. That's why we have come from the Stone Age to this Info Age and Space Age, that we always try to improve. We always try to better than what we were yesterday. So then this gave birth to two more concepts. Six Sigma. So Six Sigma is beyond CQI, wherein they say that if the error rate is reduced to 0.001, that is, quality conformance rate is up to 99.99%. So that gave birth to Six Sigma concept, which came from the Southeast Asian countries. And then that is where we are. But then there's a further improvement, and an offshoot of this Six Sigma concept, we call it lean concept, wherein we try to reduce what all is unwarranted either at the level of input or process or output, TQM, CQI, or Six Sigma. And that gave birth to concept of lean management. So this is the quality journey that we are supposed to understand. I mean, you, the delegates who are listening to me online over here right now very much. You must understand it in its entirety, and then you should try at your own place, keeping in mind your professional qualification, your work experience, the role you are supposed to play in your organization, as to how can you design your own customized solutions. You're not supposed to look at the JCI or ISQA or NABH or QCI all the time, because we are a resource-constrained country, and we have to design our own quality standards, own quality objective elements, or own quality benchmarks, so as to be able to attain them within the given set of resources and a given set of constraints. So we have to minimize the impact of constraint and optimize the utilization of resources available to meet our end objective. I hope the idea of having this program today, the two-day sojourn, would probably would help you attune yourself to look at whatever you are doing as a clinician, as a nursing professional, or in any other capacity of working. It will give one more angle to look at whatever you are doing. That's the angle of quality. Day before, I was attending the National Governing Board meeting of the NABH under QCI in Delhi. So in our country, the rate of quality conformance in healthcare industry is growing by 13.7% annually as on date. What does it mean? It means that if last year there were 100 hospitals who went for accreditation, this year it would be 113.7 hospitals. So, I mean, the quality consciousness is gradually sinking in, at least in tier 1, tier 2 cities. I hope and I believe that the 2 days deliberation, well conceived, well weaved, will at least help you give a perspective to the cause of your professional being. Thank you very much, organizers, and for conceptualizing and executing it. And I hope, rather I invite you all to immerse yourself in this quality socialism for today and tomorrow, so that you become a better professional than you are today. Thank you all very much.
Now I request Dr. Soumitra Mishra, sir, to present Dr. Harshvardhan, sir, with a token of gratitude.
Now, I would like to call upon Professor Sanjay Dhiraj, sir, Chief Medical Superintendent, Sanjay Gandhi Postgraduate Institute of Medical Sciences, to share his thoughts with us. Sir, please.
Good morning, everybody, and thanks for inviting me. It's a very important topic on improvement in healthcare. So this topic is important because if you have to see कि ज्यादातर हम लोग क्या बोलते हैं कि पेशेंट लोड बहुत है, इसलिए हम लोग क्वालिटी इंप्रूवमेंट नहीं कर पा रहे हैं। और वैसे भी इंडिया में दिस इज वन ऑफ द फैक्टर कि हमको पता लगता है कि पेशेंट लोड जो है हमारे यहाँ पर बहुत है, हर जगह पर ओपीडी में भी ज़्यादा है, इन पेशेंट में भी ज़्यादा है, इन्वेस्टिगेशंस भी ज़्यादा है, तो दैट द क्वालिटी टेक्स अ बैक सीट एक्चुअली। बट मुझे ऐसा लगता है कि मोर इम्पॉर्टेंटली जो इशू हमारे यहाँ पर पड़ा हुआ है वो ये है कि क्वालिटी इंप्रूवमेंट अगर आपको करना है या क्वालिटी एक मेंटेन करनी है तो इट नीड्स constant vigilance, constant effort, not by an individual but by a team. एक टीम वर्क चाहिए। जैसे कि आप कभी कभी आपने देखा होगा कि वॉकिंग करनी है, आप अकेले वॉकिंग नहीं कर पाते तो आप टीम बना लेते हो। आपका मूड नहीं है तो दूसरा वाला आदमी आपको प्रोत्साहित कर देता है। सो वी नीड अ टीम एंड दैट्स व्हाई आई एम वेरी हैप्पी टू नोट दैट हॉस्पिटल एडमिशंस का क्वालिटी सेल और डॉक्टर तन्मय घटक, he is the chairperson of Indian Society of Critical Care Medicine. You both have teamed up in such a way that now a quality improvement in healthcare sector can take place. We can initiate protocols, हम लोग systems बना सकते हैं जिससे कि quality improvement हमारा हो पाए। इसका importance क्या है? इसका importance ये है कि apart from the one factor which I consider very important, that is how to communicate with the patient and the patient relatives. Apart from this, quality improvement अगर आप करते हो या quality maintain करते हो किसी hospital के settings में, तो that sets you apart from other hospitals. ये दो चीजें अगर आप कर ले जाते हो तो फिर आपको पीछे देखने की जरूरत नहीं है कि आप ने ये काम किया वो काम। ये दो चीजें बहुत ही इंपॉर्टेंट है to bring the hospital in the forefront. So we should focus upon this thing, and I'm very happy कि हम लोग इस तरफ हम लोगों ने कदम बढ़ाया by collaborating with each other, which is very important because teamwork is the need of for this hour. And टॉपिक्स बताने की जरूरत नहीं है, हर्षवर्धन ने जैसे बोल के रखा है, वी हैव कवर्ड ऑल द टॉपिक्स एंड आई विश all the participants that it will be academic feast for them, and I wish a very successful conference. Thanks a lot. Thank you. Thanks a lot.
I request Dr. Tanmay Ghatak, sir, to please present our guest of honor with a token of gratitude. Sir, please.
Now I request Senior Consultant Medicine, Dr. Prerna Kapoor ma'am, to give a brief address.
Good morning to everyone, and thank you, organizers. I'll really be very brief because this is a topic where I am a learner. So I am also looking forward to the scientific deliberations. And congratulations to Dr. Tanmay and Dr. Soumitra Mishra and my dear friend, Sister Joindatta Ghosh, for organizing this very important webinar today. I always talk to Join about, quality control because she's a very passionate person in this respect. And as a nursing officer, as a senior nursing officer, she's one of the right people who can really carry out these kind of quality checks. So we often talk about this as to how we all need to learn this concept and take our hospital forward in this. So almost everything our CMS and Dr. Harshvardhan have covered. There are a couple of things I would still like to add. One is that quality control encompasses everything that we are working or striving for. जंगल में मोर नाचा किसने देखा? तो देखेंगे तभी जब हमें क्वालिटी इंडिसेस पर जब हम खरे उतरेंगे। तो जो कुछ हमें चाहिए, पेशेंट सेफ्टी, पेशेंट आउटकम्स, पेशेंट की बेहतरी और एट द सेम टाइम अ ग्रीन हॉस्पिटल। तो ये जितने भी चीजें हमें चाहिए, फार्माकोविजिलेंस इसमें आनी चाहिए और जो है मेडिकेशन सेफ्टी होनी चाहिए। तो हर स्टेप पे अगर हम ये चेक्स जो है वो अप्लाई करेंगे और इन पर हम खरे उतरेंगे और अल्टीमेटली क्वालिटी को जब हम इम्प्रूव, then that is when we are really achieving something and going forward as a healthcare delivery institution. The second thing is that we are a mammoth institution. अगर SGPGI को हम लें, हमारे कितने सारे हमारे व्हील में कितने सारे कॉग्स हैं, तो ये जो मशीनरी है ये सबके मिलके चलने से चलती है। सो क्वालिटी कंट्रोल से बेटर इस चीज का कोई एग्जाम्पल नहीं है कि वी आर ऑल स्टेक होल्डर्स। हर कोई, हर किसी की जिम्मेदारी है कि वो अपने काम में क्वालिटी चेक लाए और हर एक चीज में चेक लिस्ट को फॉलो करे और अल्टीमेटली मिलजुल कर सबकी भी जिम्मेदारी है। So congratulations again to everybody who has helped organize this webinar today. And congratulations to all the listeners who are going to, all the delegates who have joined physically or online, who are really standing to gain. So thank you again. Thank you.
Thank you. Very valuable words. Now I request Dr. Utsav Anand Mani sir present our guest of honor with a token of gratitude.
Now, I humbly request all of our esteemed guests to please come on the stage and let's go for the lamp lighting ceremony.
तुषारहार धवला या शुभ्रवस्त्रावृता या या शुभ्रवस्त्रावृता या या ब्रह्मा चिदर्शन प्रकृति सरस्वती भगवती
I now request Sister Joinder Ghosh to please present a token of appreciation to Mrs. Usha Takri ma'am.
I request Dr. Somit Mishra, sir, to present our guest of honor, Dr. Rajesh Harshvardhan, sir, with the token of appreciation.
I request Dr. Tanmay Ghatak, sir, to present our guest of honor, Professor Sanjay Dhiraj, sir, with a token of appreciation. Sir, please.
I request Dr. Utsav Anand Mani, sir, to present our guest of honor, Dr. Prerna Kapoor, ma'am, with the token of appreciation.
Good morning.
Abhishek sir, are you able to hear us?
Yeah.
So please share your slides. So
I had already mailed Start play from your side.
Okay, I'm saying everyone will begin with the scientific session in a short while. Please wait. We'll begin with our scientific session now. Pharmacovigilance has pivotal role in safeguarding patient well-being by detecting, assessing, and preventing adverse drug reactions. So let's embark upon a journey of enhancing medication safety and quality care delivery. With this, I would like to call upon our first speaker, Mr. Abhishek Bera, sir, to give them overview on quality healthcare.
Good morning to all the participants. My name is Abhishek Bera. I'm working in PLS Hospital, Kolkata, as a quality senior executive quality assurance department and NABH and NABL audit team and quality manager of the hospital. Let's first start with our PPT. Can you please share the PPT? Okay, thank you. Next slide. No. First, before starting the session, I'm just going to the table of contents. First is history of quality, and next key factors of quality improvement project, and next method and access of and improvement, and then strategies, and then I'm going to the statistics of quality improvement. First, I'm in the quality, healthcare quality. In the early, next slide. In the early 1900, Dr. Ernst Codman, next slide, please. In early 1900, Dr. Ernst Codman of Massachusetts General Hospital first suggested the measure the track proven patient record means of effectiveness there. Means suppose when they are providing the services to the patient, they first identify that one effectiveness is required and tracking of patient improvement is required. So that when they started the quality journey. After that, in 1917, American College of Surgeons
first established the quality standards of hospitals, means first quality concept. After that, in 1951, American College of Surgeons with certain several professionals, first concept have raised of Joint Commission of Accreditation of Hospitals, which we know that JCI. Almost after that, almost 30 years later, the accreditation concept came to India, and the one board committee has founded in 1943, and they recommend the NABH or NABL and quality concept they have raised, that how to improve the patient track record, how to measure the patient track record, how to improve the quality, and how to measure it. Okay. So that from that where 1943, we have in India started the quality journey. Next. Next slide. Next slide. No. Previous slide. Second point is key factors. Now I am telling that the history, and now came into point that the key factors of quality improvement. Key factors means there are 4 key factors. Next slide. One is patient safety. Next slide, please. One is patient safety. One is patient safety. Next is clinical effectiveness. Then patient satisfaction and equity. First, quality improvement key factor is patient safety. That is the most key factor of the quality improvement project. Means whatever we are doing in the quality related or any clinical related, that's the ends with patient safety. Means if patient safety is not measured properly or patient safety is not evaluated properly, then quality improvement will not go on. Okay. Then in any procedure, whatever we are doing, we can measure the quality indicators, we can measure the audits, we can measure the clinical audits, then we can do the internal audit. All those factors moving towards the patient safety. Patient safety is the main key factor. And next, we can move to the clinical effectiveness. There are 2 effectiveness. One is clinical effectiveness, another is non-clinical effectiveness. The main key factor is clinical effectiveness. Clinical effectiveness is the evidence-based practices. Evidence-based practices means, suppose the mortality in a hospital, in a certain percentage of a hospital is 10%. And if we are not measuring those factors, then our mortality rate will not improve. Okay. Or we can say that mortality rate, how can we improve? Or we can say that in equus participation, means external quality assurance scheme, where the laboratory results are evaluated. So if we do not have the evidence-based practices, so we can't move to the evidence-based and clinical effectiveness, we can't move. Third point, very important, that is patient satisfaction or patient outcome, we can say. Patient satisfaction we can measure through the feedback, through the complaints study, and all other way where they are moving the Google review. On any other sector, we are moving the daily basis, means Apache score, or other way we can move the patient satisfaction, or we have to make the strategy to how we improve the quality factor. And the fourth factor is equity. Equity means we can say that we can financial status, means suppose we are moving to a HIC policy, hospital infection control movement. So if our equity is not permitting to that, we can't move to that way, or we can't move to the several changes. Or we can say that in laboratory area, in clinical area, we can say that pressure ulcer is one of the factors. We can move to the pressure ulcer management, so that we have to move to the financial status or gender, race, we have to move them. Okay, these 4 are the quality improvement factors. Next slide. Next factor is very important. Now I am telling that the key factors, the main method. Then we have to move to the methods and access to improvement. One means how we can move to the methods and how to access and improve the process. One common model is Donavedian model. If you move to the quality journey, we can always see that one Donavedian model is Donavedian model is there, where they have a break into the 3 process. First is structure, next is process, and another is outcome. Structure means I am already telling that we have, if we are working in a hospital or healthcare setup, then we have to move properly a structurized way. Means suppose a bed movement, bed space, or we can say that we have categorized staff. Categorized staff means we have certain qualification we have to maintain, certain experience we have to maintain. We can say that the supplies mean in the sense we can say that in clinical supplies, non-clinical supplies, the infection control related supplies, the CSSG supplies, all those are involved in structure. Now we have maintained a structure of that we have a well-established structure. Or suppose we have some guideline and hospital guideline means we have to follow that protocol. Nursing protocol we have fixed. We have to follow the nursing protocol. We have to follow the Humpty Dumpty scale for patient fall. Okay. So that are the guidelines that we have to follow. Now we have maintained the structure, and next process is process. Process means we have analyzed the structure, but we don't have the process. Process means how we have to run the process. Means suppose, for example, we have set up a good hospital bed, but we don't have the proper nursing staff, or we have the proper clinician, we have the proper RM who interact with the patient, or we who not interact with the patient. That is the process. Another we can say that in investigation. Investigation means here laboratory investigation, radiological investigation, or at the part of process. Process means suppose the patient is admitted to our hospital, we are not properly investigated all the investigation, or we have not done the properly biopsies, radiological process. Then how we identify that and how we improve the quality of the patient service, or how we examine the proper treating patient. Next point is treating counseling, treatment counseling. Treatment counseling means every day you know that in 8-hour shift nurses are counseled properly, and doctors are counseled twice a day. That is the main part. Means counseling is patient counseling, patient party counseling. Patient counseling means in everywhere we are moving to the any process. Means for example, we are doing some procedure, colonoscopy procedure, some blood transfusion. All the way we need the counseling, patient counseling. Some dialysis is required. That is also counseling is required. That part is done. Few of them they are doing the nursing stuff and doctor is doing. That is the process. And next, the third point, that is outcome. Means we have structured all the stuff. Then we have done the process ourselves. And next third point is outcome. Outcome is patient satisfaction and mortality and morbidity. That is what I have already told that. The outcome means mortality, morbidity and patient satisfaction, which is the ultimate our goal to improve the outcome. Okay. Next. Next slide, please. Next slide is another is I'm telling the donor-obedient skills. Another perspective is organization perspective, healthcare professional perspective, and patient perspective. Organization professional perspective is that how organization is moving towards, and how organization is thinking about the quality improvement journey. Means organization changes, organizational improvement, how tracking is that. Second point is healthcare professional perspective. Means who are we are healthcare professionals, means nurses, doctors, paramedical staff, all are healthcare professionals. Their perspective is very important because they interacting with the patient. So their perspective is very much important, how they are feeling, how their patient outcome is coming. And third point is patient perspective. Patient perspective is how patient is feeling that. Means in counseling, how patient is feeling better or not, how patient is moving towards, means how they at the time of discharge, how patient is telling that what is their process. And in next time in OPD, we are telling that how patient is doing. In OPD, we can say that what is the waiting area of waiting for doctor consultation, what is the waiting area of radiological process, what is the waiting time for outdoor doctor consultation. All are the patient perspective. So all the three perspectives are required in quality improvement of the hospital. Next. Now we are doing the structure, we have the process, and we have the outcome. Now all these things are included in India. We are telling that NABH, that is National Accreditation Board for Hospital and Healthcare Providers. They are one accreditation body. They are come and access all the points, whatever I am telling that, and measure all the things. That is done by Quality Council of India. That is the first quality improvement project they are running in the NABH in the India. Okay, another thing is that the JCI also has, but that is not formed in India. That is from American College of Surgeons, I've already told. So NABH and QCI is found in 2005, and they are running the principal accreditation on hospitals in India. Okay, next point. Next slide, please. Strategies in healthcare quality. Now I am telling all the process. Now, how we can strategize all the points, means strategies in healthcare quality. So how can we measure the points? How can we calculate the points? In my next slide, it is written. Okay, next slide, please. Next slide. First, we have to build up our base team. Means build up our base team means not in qualification related, how they are working together, how they are calling to each other, how they are find their bonding there. That that consists of a clinical person, that consists of nursing person, that consists of housekeeping person, non-clinical person, OPD person, IPD floor coordinator person. We have to build a base team. Next, analyze your data. Analyze your data means we have to analyze all the data. That may be positive data, that may be negative data. We have to collate all the data and analyze our data. Next, create a successful plan. Should be, but I am saying successful because if we do analysis of data, then definitely our plan should be success. And create a successful plan means how we run our organization with quality improvement. And next, collaborate with other organizations. That is very much important. Collaborate with other organizations means those who are already champion in the sector. Then we have to collaborate with that organization, and I set idea from them and collect idea from them, how to run from, how we can learn from them, how we can memorize all the things from them. And next, set the goals. Now we have collaborate all the things, create a successful plan, create a team. Now set our goals. Means what is our goal? Suppose what our goal is to reduce the mortality rate or reduce the pressure injury rate. Then we have to all the things and set a goal that in next 6 months or 1 year, we have to reduce it to 5%. Then that is our goal. Next, focus on your patient. Focus on your patient means we have to re-counsel and focus. Patient visit is required, patient party visit is required, how infection reinfection is doing, how reinfection control is processing, how patient is telling what he is or she is feeling to our hospital. And next, seven number point is constantly update your vision. Update your vision means all the sector we have covered in 6. Now we have to do from 1. Again, we have to go to the 1. That is called PDSA cycle. Plan, do, check, and action. PDSA cycle, we can say that constantly update our vision, and we have to go back to point number 1. That build your team. Again, we have to build our team, second team. Those who will, suppose we have to change our do sector to sector. Means suppose we have to analyze in one section, and we have to all the things we have to set, and next we have to move to the second section, and we have to do all the sections. When quality improvement is done in one sector, then we have to move to the another area or another sector and moving to the next session. Okay, next slide, please. Next. Statistics of quality improvement. Now I have told what is quality improvement, how we are running. Now few of the quality improvement statistics which are published already. In 2019, Agency of Healthcare Research or AHRQ run a study and saying that the hospital readmission is reduced by 20% by intervention quality improvement. In 2018, another study is done by Commonwealth Fund study. They telling that patient receiving from hospital strong quality improvement program, heart attacks or stroke has been reduced. In 2017, CDC, we know that Center of Disease Control and Prevention, they have run a quality improvement project, and they are found that the hospital associated infection has reduced to 60%. And 2016, JCI have found a quality improvement rate. They showing that the mortality rate has been improved. Improved and mortality rate has been down. So that is all the quality related issues and how we can run our quality improvement project. and how can move to the quality improvement. And if we are moving to the quality improvement, what is the status of that, and how to set a goal, how to found a team, and how to analyze our data, how to reinfection of our data, how to moving, we can say that in a GH we have, if we are not moving to the Senate, that is not issue, but we have to move our team and set our team and improve the quality improvement project. Okay. Okay, this is my session. Any question?
Thank you, sir.
Thank you.
Now, pharmacovigilance has a pivotal role in safeguarding patient well-being. By detecting, assessing, and preventing adverse drug reactions. So let us embark upon a journey of enhancing medication safety and quality care delivery. With this, I hand over the forum to Professor Shubhra Jyoti Bhaumik, sir, to give us a profound understanding of pharmacovigilance in hospitals. Sir, please. Shubhra Jyoti Bhaumik, sir.
Yeah. Just give me a minute. I will pull in my slides. Just give me a minute.
Welcome.
Well, thank you. Thank you so much. Thank you. Thank you, Jude. Thank you to the organizers for inviting me here. It is a great opportunity to be amongst this learned audience, and especially such a great conference, a webinar which is being held on healthcare quality and patient safety. I would like to take this opportunity to thank Ms. Jui Ghosh, who has been the instrumental person for inviting me here. She incidentally passed her nursing from our college, which is at PLS Nursing. So it's it's so heartening to see that she's doing so good for herself at a very reputed institute in India. So let me quickly pull my slides. I'm going to talk about pharmacovigilance in hospitals. Just give me a minute. I'm going to pull my slides. This is taking some time, but this was a heavy presentation. Just a minute. Sorry, just give me a minute. I'm just opening the slide. It's taking some time because the laptop has hanged. Just give me a minute, please. No problem.
जैसे आप ये सीरियल का आपसे बहुत करना है कभी एक बार रिश्तेदार Good morning, ma'am. कैसे डर मैम वो MICU का
तो सबको करवा देगा भाई तो हम चलो बात करते हैं।
It's opening. So today I've been asked to speak on pharmacovigilance in the hospitals. And let me tell you that SGPGI is itself a big center where pharmacovigilance is being done. So it's a huge session, baby. It's a huge session. It's a huge session. लिखे दिए जाओ कि ठीक ভালো আছে তোকে just পাসওয়ার্ডটা লিখে দিয়ে যাও ওখানে যদি এটা ফেল করে আমি ওখানে So I'm to just a brief of vigilance is and how India is doing with respect to pharmacovigilance. So firstly is why pharmacovigilance is important, because patient safety plays a very important role in terms of pharmacovigilance. And pharmacovigilance, what is pharmacovigilance? If I could just tell this, that we as a country we are very different, and the reason why we need pharmacovigilance will be discussed in this particular session. So I begin with my conflict of interest. I have none to declare, and the entire ethos of pharmacovigilance stands on this Hippocratic oath, which is to do no harm. Primum non nocere. We as doctors, we as nurses, we as pharmacists always take this oath that even if we are not able to treat anybody, we should not harm anybody. That is the ethos of patient safety. That is the ethos of healthcare quality. So it comes from two words. Pharmakon means the medicinal product in Greek language, and vigilare means keep watch. So I'll start with a small quiz. Patient X, this patient could come to SGPGI as well, has come to your medicine department, has been found to be suffering from pneumonia, was started on a new antibiotic. We prescribe antibiotic left, right, and center. Clarithromycin 500 milligram 4 times daily in the OPD. 12 hours later, patient complained of chest discomfort, severe palpitation, resulting in the patient coming to the emergency of the SGPGI Lucknow and getting admitted. What is this event? Is this an adverse drug event, adverse drug reaction, serious adverse drug reaction, or sure? Can you unmute and please let me know what is this event? Anybody who would like to answer this? Because this is the practical aspect of pharmacovigilance.
Sorry, sir. Your PPT is not showing.
It's not showing, is it? Okay. Just a minute. Is it now showing?
No, sir. Yeah.
Yes.
Okay. Okay. So I will start with this quiz because there are many healthcare workers, doctors, nurses who are sitting here. This patient has come to SGPGI Lucknow, got clarithromycin for pneumonia. Again, after 12 hours of taking, he complained of chest discomfort, severe palpitation, and is admitted in the emergency. What is this? Is this an adverse drug event reaction, serious adverse drug reaction? And how many of you are not sure? At least there could be some people who are not sure. And that is the majority of the section. Any thoughts on what this reaction is? Because this is where we are missing in the pharmacovigilance puzzle. We are not reporting these events. We are not reporting these events actually. So let us see what is reported as. What is the WHO definition of pharmacovigilance? It is the science and activities related to detection, assessment, understanding, and prevention of adverse events or any other drug-related problem. Now, majority of the people in India, they only do detection. They don't assess, they don't understand, they also don't take steps for prevention of adverse effects. This is the entire gamut of pharmacovigilance. We also have to, we need to exclude therapeutic failures, drug overdose, drug abuse, non-compliance, and medication errors, which is a completely different ballgame altogether. So the history of the dreadfulness of absence of pharmacovigilance. Let's see what happened in 1959 and 1961. There were 10,000 babies born in England with this kind of a disease, which is phocomelia, because their mothers took thalidomide because of morning sickness. Why this happened? Because thalidomide did not have any pregnancy information in females. It did not have any safety information. This was the first time that the world realized that there could be a lot of adverse events which we are not monitoring. So 1961, the thalidomide disaster happened, resulting in 1963, the World Health Assembly adopting a resolution on adverse drug reaction. In 1968, the WHO started the Pilot Monitoring Center for Adverse Drug Reaction. And 1977, it advocated establishment of National Center for Drug Monitoring to provide guidelines for pharmacovigilance. In 1962, the United States brought in the Kefauver-Harris Amendment, which said that any drug which has to be applied to the human beings must have animal data in pregnancy. 1964, the Yellow Card Scheme was launched in UK. Yes.
So the slides are not moving, sir.
Yes, please.
The slides are not moving,
okay.
sir.
What is the slide you are seeing?
The introduction slide.
Oh, that is quite disappointing. Just a sec. Are you able to see now?
So we can see the slides, only the introductory slide only.
It's not moving at all. Can I mail my slide to let me mail my slide to Ms. Ghosh. Can I mail it to you or can I send it to you right now? Will that be okay? Quite interesting why the slides are not moving.
Yes, so you can mail the slide to her.
Okay, let me just see again once more. अभी दिख रहा है आपको एक सेकेंड is loading. अभी
Yes, sir. Now we are on slide number 10.
हाँ तो मुझे लगता है फुल स्लाइड नहीं कर सकते, ऐसे ही करेंगे फिर. ठीक है, ऐसे दिख रहा है ना?
Yes, sir.
ठीक है, अगर नहीं दिख रहा होगा तो बता दीजिएगा, then I will send it. तो मैं हिस्ट्री बता रहा था. I was talking about the history. It started with this. See, this is a very dreadful thing. Are you able to see this particular child which does not have the limb? Are you able to see? This
Yes,
is the
sir.
thalidomide tragedy. This happened. Yes, दिख रहा है आपको?
Yes, sir.
Yes, sir.
हाँ, so ये थैलिडोमाइड ट्रेजेडी से शुरुआत हुई फार्माकोविजिलेंस की 1959 में 10,000 pregnant ladies they just consumed this pill because their gynecologist had told them कि it will help them from morning sickness. Look at the condition of their children, all born with no limbs, and the world was totally shattered that what happened. So this is the beginning of pharmacovigilance in 1959. The thalidomide tragedy made people understand that drugs are not safe. There is nothing called a safe drug. Vigilance is required. 1963, the World Health Assembly adopted the resolution of those drug reactions. 1960, WHO Pilot Monitoring Center was set up in Sweden. Sweden does a lot of pharmacovigilance. 1977, WHO advocated the establishment of national centers for drug monitoring to provide guidelines. In 1962, the United States brought in a special regulation by the US FDA known as the Drug Efficacy Amendment Act, also known as the Kefauver-Harris Amendment Act, which said that any drug which will be launched in the United States must have pregnancy-related animal information data. Before 1962, no such information was brought into the new literature or into the drug literature. 1964, the United Kingdom allowed their GPs and their doctors and their nurses to report any adverse drug reaction through an yellow card, which was an envelope. And this envelope used to go to the drug regulator in the United Kingdom. It is still prevalent. 1986, India joined the ADR monitoring mechanism. But still, there was a lot of pushback from the Indian side, as a result of which it was only in 1997 that India formally joined the WHO ADR Monitoring Center. You see, why do we need pharmacovigilance? Because this slide can be spoken for 35 minutes. But if we understand the mechanism at which a new drug is developed, all of you have taken Crocin. No, I'm taking the name of paracetamol. Have you ever thought paracetamol kaise bana, kaise uska development hua? We don't know this. We just pop in the pill, considering it that it is safe. Paracetamol first was tested in animals, which were the animal models of fever. Then it went into the phase 1 in healthy volunteers between 18 to 40 years of age. Then it was again given in fever patients in phase 2, where there were 100 to 500 patients. Then there were 500 to 1,000 patients, and it was approved by the government. So it was only in few thousands that we take a decision that the drug is safe or not safe. But what is the population of our country? Can anybody tell me what is the population of our country?
145 crores.
इस पे तो आंसर होना चाहिए. 145 crores. So can speculation that 45,000 people may safe hai? Can we say that 145 crores may safe hai? Can we say that? Answer is no. And that is the reason we need pharmacovigilance in hospitals. This is the very important part of post-marketing safety surveillance. Why do we need it? Because insufficient data comes from clinical trial. I will take this opportunity to share. आप सबको COVID vaccine लगी है? All of you have taken the COVID vaccine. The COVID vaccine, Covishield, was developed on only 4,000 Indians, and it was given to 80% of the Indian population. So can you imagine the precision in which the clinical trial was conducted? So we need pharmacovigilance because in clinical trials, there is narrow population, there are only specific indication, and it is only for shorter duration. जो कोविशील्ड की ट्रायल थी वो सिर्फ 6 महीने चली थी. But जब इंडियंस में दिया गया, when we got to get it to Indians, we first got 2 doses, doctors got 3 doses, nurses got 3 doses, and there was a discussion of giving 4 doses. We don't know the safety, hence safety data has to be completed. There is a huge need for pharmacovigilance because there is a huge economic burden. In the United States, at least $2,262 is data from KEM Mumbai. One ADR in KEM Hospital Mumbai cost around 6,000. This is before COVID. Now this must have been triple the cost. 18,000 रुपए लग रहे हैं हमको on an average to manage an ADR. Who are at greater risk? So all the nurses and all the doctors who are listening to this, if you are treating children, if you are treating elderly people, if there are physically challenged people, if there are people in ICUs, elderly people, 20% of our Indian population are elderly now. सबके घर में बुजुर्ग हैं. We have senior citizens in everybody's house. They are at high risk of adverse drug reaction. People who have allergies and anybody who's being discharged from the hospital. I will not get into details of these definitions, but people confuse between adverse drug event and reaction. What is a reaction? Where you have a causal association. Where a causal association does not form, it is an adverse drug event. What is the meaning of causal association? There is a tool, causality tool by WHO and by Naranjo. Somebody who's only collecting the ADR. So in many hospitals where I go for NABH assessment, I see the people only collecting ADR. हाँ ये reaction हो गया, penicillin दे दिया, ये reaction हो गया, इससे ये हुआ. लेकिन क्यों हुआ? उसका कारण क्या था? वो कारण ढूंढने के लिए causality assessment करना पड़ेगा. और this is the scale. I would recommend SGPGI and other people who are attending this to please implement this scale. One scale is WHO UMC scale, and the one which we use at our hospital is the Naranjo scale. See, there are 10 questions, and every question has got a yes, no, don't know aspect. And every yes, no, and don't know has got marks in it. So the total marks, if it is 9, then it is a highly probable ADR. If it is 0, then it is a doubtful ADR. ऐसा नहीं हो सकता कि मुझे लग रहा है ADR है तो ADR है. नहीं, it is a scientific method in which ADR is calculated, is done across the world. And many countries, including India, is also doing it. A serious adverse drug reaction is a special type of adverse drug reaction which results in death, results in inpatient hospitalization or prolongs the hospitalization, results in permanent disability, is life-threatening or congenital anomaly. So अगर हम अपने patient के पास जाते हैं जो SGPGI में आया था, वो patient को clarithromycin देने के बाद patient को admission कराना पड़ा था. Patient got admitted in the hospital. So this is a serious adverse drug reaction. This has to be reported as serious adverse drug reaction and not an adverse drug reaction. यही सीखना है आप लोगों को, यही सीखना है कि रिपोर्टिंग कैसी करनी है, क्योंकि रिपोर्टिंग अगर हम अच्छी नहीं करेंगे तो it will not serve the purpose. There are various classification of ADRs on onset severity. If it is less than 60 minutes, acute, 1 to 24 hours, कोई दवाई ली आपने और आपका सर 24 घंटे तक चक्कर मार रहा है तो it is in subacute. More than 2 days, नींद आपको 2 दिन से ज्यादा आ रही है तो it is a latent ADR. Type A ADRs are one which are extension of pharmacological effect. Means अगर आपने propranolol, it's a beta blocker, it leads to heart block. It is a type A ADR. Type B is, we don't know why it happened. Immunological reaction. Chloramphenicol is a very old antibiotic given in children, can produce aplastic anemia. It is a type B ADR. Type C ADR है anti-malarial, जैसे chloroquine. बहुत commonly we give chloroquine very commonly. अगर उससे ocular आंखों में problem हो रही है, that is a type C ADR, chronic effect. And type D is teratogenic effect. Pregnant mother को अगर बच्चे को ADR हो जाए, that is type D ADR. There are various methods of ADR reporting: passive, stimulated, active. I'm not going to go into details. I'm just going to tell you that please do some method. Stimulated reporting ADRs, where you encourage people in a particular specialty to report ADRs. Healthcare workers, like in the Department of Radiology, in the Department of Oncology. This is our paper, which is published in the International Journal of Basic and Clinical Pharmacology, where we looked at very simple study, 1-year study on the non-ionic contrast medium in Indian population. You will not believe till 2014 there was no data on the non-ionic contrast. जो radiology में हम contrast use करते हैं, whether it is safe or unsafe. ये बड़ी simple study हमने की थी जुलाई 2012, जुलाई 2011 से जुलाई 2012 में, and we found out that our Indian ADRs are less with non-ionic contrast medium. So this is a very typical example of a simulated ADR. Active surveillance is a pre-organized process where you give more training, more focus on reporting the ADRs. And this is a study which we did in the Department of Psychiatry, where we looked at more than 2,000 psychiatric patients and we reported ADRs in this very big hospital in SSKM, which is in Bengal, in West Bengal, around 2,000 beds in this hospital. This was the OPD-based study done way back in 2009, where we looked at that whether the psychiatric patients, they report the same adverse drug reaction like the Western population. Believe it or not, maximum ADR which we get in our country is from the Western population, but we are different. हम लोग unique हैं. We have to be, we have to be different. We cannot take the Western data and extrapolate it because we are very genetically from the Western population. These are various tools. Anybody who's interested can search on web on Medra. This is the tool which we used in hospitals to ADR monitoring and ADR classification. VigiFlow and VigiBase is being used by the Pharmacovigilance program of India. So VigiFlow is actually the database flow where the individual case, if SGPGI uploads the individual case, it will go into the VigiFlow system of India, and the VigiFlow then sends this entire information to Uppsala Monitoring Center, which is the headquarters of pharmacovigilance in the world. And this is one example I want to show you that what we are doing in India. India is doing a great work. India as a country has started the pharmacovigilance program of India because we are 1.4 billion people. We have a lot of genetic and ethnic variability. There is disease prevalence and there is huge generic market. Multiple drugs of the same composition are available in this country. So India formally started the pharmacovigilance program in 1986, and we have come a long way. Since 2011, the National Pharmacopoeia Commission, the Indian Pharmacopoeia Commission is monitoring, has become the main center in Ghaziabad. The Indian Pharmacopoeia Commission has become the main center to take forward the pharmacovigilance program of India. And I would request everybody to go to the PVPI website. Lot of work is being done by PVPI in our country, and we should be proud about it. Can I ask somebody, this is just a question, do you 1.4 billion people, we have so many pharmaceutical companies, what percentage of the ADR base do you think India is contributing? Is it 50%, 60%, 2% or 12%? Any guess? एक guess लगाते हैं चलिए, कितना हम कर रहे हैं, वर्ल्ड को हम कितना दे रहे हैं डेटा? Any guess तो लगाना पड़ेगा. Are we doing 50% or we are doing 12%, 2%? If we are an India lover, we will say 60%, but unfortunately not. We are actually doing 2% of the reporting. Lot has been done. There are more than 200 monitoring centers now, actually now up to 700. There is a lot of engagement with the pharmaceutical industry. There is a mobile app which has been launched by the PVPI. Please download the mobile app for ADR reporting. Drug safety alerts are being sent to people like you. It is the drug safety based research is being done by PVPI and continuous training and skills being done. I am a trainer at the PVPI program at Ghaziabad. So I train, I've done hundreds of trainings for so many healthcare workers across the country. And what people say, हम रिपोर्ट करते हैं, इससे क्या फर्क पड़ता है? फर्क पड़ता है, आपके रिपोर्ट से फर्क पड़ता है, बिकॉज ये जो रिपोर्टिंग आई है उसकी वजह से BCG वैक्सीन से लिम्फेडेनोपैथी होती है, ये ऐड हुआ है. जो रिपोर्ट आई है भारत के अलग अलग प्रदेशों से, उससे डॉक्सीटैक्सिल जो एक एंटी कैंसर ड्रग है वो कैंडिडियासिस करता है, ये दिस वाज नॉट रिपोर्टेड इन द वेस्टर्न पॉपुलेशन. This has been reported And this is totally been from our population, and the drug and the healthcare workers have been told. So there are a lot of activities which are this report is generating, and this is resulting in safe prescribing. This is the data flow of PVPI. Healthcare workers like you will put this through your center, goes to the National Coordination Center. Data is looked in the VG flow, and through this, it is going to the global database. So what you are filling at SGPGI is actually going to Sweden, and you are contributing to the global database. There are various methods of reporting. ADR reporting forms आपके hospital में available है. एक टेलीफोन नंबर है जो मैं आपको बता दूंगा. There is an email and mobile application. This is the ADR form which contains the patient information, the suspected drug reaction, suspected medication, reporter details, and this is for the center to fill up. Agar a patient receives penicillin or piperacillin tazobactam injection and develops redness of the body after that, we need to report that. When the reaction started, when the reaction finished. This is the helpline number of the PVPI where you can report 180-180-180-3024, where you can report the ADR which you come across. And the healthcare workers not only report, this is also being reported by the consumers as well. We can send emails to pvpi.ipcindia@gmail.com. These are regional training centers. So in the northern region, you have the PGI Chandigarh, which is training, and these are the centers in the rest part of the country. So to finish, I would say apart from pharmacovigilance in drugs, pharmacovigilance in vaccine is being done by our Indian government. And there is the district immunization officer, which is undertaking the adverse event following immunization for every vaccine which is being given through the National Immunization Program. Hemovigilance program is launched in the country. Many of the people might think why I'm talking about hemovigilance. Blood is a drug. Please remember, blood is a drug, so you will have to report any adverse reaction due to blood transfusion. There is this hemovigilance is launched since 2012, and there are many reports which have gone to the Indian database. But still, we will have to report a lot. See, out of the reporting which is happening in the world, more than 70% of the reporting is by the United States of America. And as a result of which, US is telling us which medicine is safe and which medicine is not safe. We cannot take this. We have to build our own database. We have to make safe prescribing for our own population. We want to make our patients safe ourselves. So, and paper which we wrote back in 2015. Yes. No, will be in LT3. This is a paper which we wrote to the International Journal of Risk and Safety in Medicine, which we told that we need our nurses to be trained in pharmacovigilance, because I salute the nurses from here. The nurses are the backbone of hospital and they are doing the maximum reporting. So we need doctors to report, we need nurses to be trained in pharmacovigilance, which unfortunately is not being done in every nursing college of this country. Maybe it is done in SGPGI, not being done in every nursing college. So to summarize, I will say ADRs are very common in healthcare. It is happening in your hospital, it is happening in my hospital. It is an inherent risk of using medication and does not signify negligence of the healthcare worker. Safety improvement activities should include identification, reporting, analysis of the error. A dedicated team should be led by a clinical pharmacologist. SGPGI has the pharmacology department. So pharmacology department, I'm sure, is playing an important role in this. The goal is to develop a culture of ADR reporting and pharmacovigilance healthcare system. And I strongly suggest and recommend that nursing and pharmacists also have to report. Their curriculums have to undergo modification to make pharmacovigilance a very important part to strengthen the pharmacovigilance program of India. So to conclude, I would say that there are no biologically safe drugs. There are only safe physicians, safe nurses, and safe pharmacists. Let us all take pledge to become one. Thank you very much for this opportunity. If there are any questions or comments, I'm more than happy to take it.
Hello, sir. I have one question regarding the
Yes, please.
regarding the causality assessment of adverse events. Like, if any
Yes.
drug side effect is reported, what should be the causality of that?
If any, can you please repeat the question? If any, what is reported? ADR is reported, is it?
ADR is reported, and which is the side effect of the drug, then what should be the causality of that?
Yes. Yes, so it's a very good question because it's a very common thing which people are confused. See, if you report, whenever reporting is happening, it should be reported in a reported format by the government, which is already given by the government. And once you receive the report, you will have to apply a causality tool. मैंने जो आपको बताया नरंजो स्केल में 10 questions हैं. There are 10 questions in Naranjo scale. I'm just going to just for one last minute, I will pull the Naranjo scale because the gentleman has asked me, and this is the question which is asked by majority of the people कि Naranjo scale है क्या? ये जो Naranjo scale है, आपको अगर ये दिख रहा हो, sorry, ये पता नहीं क्यों full screen पे आ नहीं रहा है. क्या ये full screen पे आ रहा है अभी? Are you able
No,
to
sir.
see the Naranjo scale on full? No. So there's some problem with the software. But anyway, this are you able to see this right now? The scale, are you able to see the scale? Are you able to see the scale? Abhi dikh raha hai? Good morning. Are you able to see the scale?
Yes, sir.
अच्छा दिख रहा था ना, ठीक है. एक सो हाँ, ये स्केल पे अगर आप जिन्होंने क्वेश्चन पूछा है, देखिए इसमें 10 क्वेश्चंस हैं. जो आपका ईडीआर आया उस पे आपको ये क्वेश्चंस पे आंसर करना पड़ेगा. कि नंबर 1 क्वेश्चन है, आर देयर प्रीवियस रिपोर्ट्स ऑन दिस रिएक्शन? इफ द आंसर इज यस, तो यू गिव अ स्कोर ऑफ +1. डिड द रिएक्शन हैपन आफ्टर सस्पेक्टेड ड्रग वाज एडमिनिस्टर्ड? आंसर इज यस, सो स्कोर 3 पे चला गया है. 1 + 2 3. Did the adverse drug reaction improve when the drug was discontinued? पता नहीं, क्योंकि हमने उसके बाद तो हाँ बंद कर दिया, शायद है, नहीं है, don't know. So 0. So 3 पे score है. Did the adverse drug reaction appear when the drug was re-administered? Many people don't re-administer the drug, but some people re-administered the drug. If the answer for this, did the reaction appear when the drug was re-administered? If the answer is yes, +2 हो जाता है score. The score is reaching to 5. अगर वो नो है तो -1 हो रहा है. ऐसे करते करते ये 10 क्वेश्चंस हमें पूछने हैं. ये सारे 10 क्वेश्चंस हमें पूछने हैं और फिर अंत में जाके हमें ये स्कोर देखना है कि स्कोर कितना आ रहा है. अगर 9 हमारा टोटल स्कोर है तो ये हाईली प्रोबेबल है कि ये एडीआर हाईली प्रोबेबल है कि इस दवाई की वजह से हुआ है. अगर स्कोर 0 है तो ये डाउटफुल है. 1 to 4 के बीच में स्कोर आया तो पॉसिबल है. 5 to 8 के बीच में आया तो ये प्रोबेबल है. तो ये बड़ा ऑब्जेक्टिव स्कोरिंग है. यू हैव टू यूज दिस टूल. अगर आप टूल नहीं यूज करके बोलते हैं कि क्लिनिकली हमें लगता है कि ये रिलेटेड है, नॉट रिलेटेड है, उसकी कोई वैल्यू नहीं है. देयर इज नो वैल्यू ऑफ दैट माय एक्सपीरियंस काइंड ऑफ फंडा, वो नहीं है. बिकॉज एविडेंस बेस्ड गाइडलाइन से यू मस्ट हैव अ टूल टू असेस इट. सो every causality should be done with the help of Naranjo's ADR causality scale. Did I answer my question? Did I answer your question? Is that okay?
Yes, sir. And in the Pharmacovigilance program of India, we follow WHO scale.
हाँ, कोई बात नहीं, आप WHO भी कर सकते हैं. एब्सोल्युटली. ये दूसरा स्केल जो मैंने दिखाया था, एब्सोल्युटली वेल एक्सेप्टेड स्केल है. ईदर ऑफ द टू you can accept, and PVPI definitely asks us to do the causality scale. Personally, I like Naranjo because इसमें objective scoring है. WHO में objective value है, लेकिन दोनों ही ठीक है. Both of them are okay. We cannot say one is bad, one is good. Both of them are okay.
Thank you,
So
sir.
thank you for this opportunity. Thank you, Jui, for this opportunity.
Thank you, sir.
Thank you so much, sir, for sharing your critical insights, sir. Thank you so much. With this, we now shift our focus on patient safety goals, which are crucial benchmarks aimed at enhancing quality of care and minimizing the risks within the healthcare settings. And now I invite our next speaker, Ms. Gagi Das ma'am, to please commence with her presentation. Ma'am, please.
Good morning, everyone. Hope I am audible.
Yes, ma'am.
Am I audible? Okay.
Yes.
Thank you so much for the invitation. And it is a great opportunity to present in front of such a learned professions, my colleague. And June, thank you so much for the opportunity. So I will share my screen. Is it visible?
Ma'am.
Yeah.
Welcome, Gagi.
So the topic I got is International Patient Safety Goal. So in this era of patient safety and in healthcare, patient safety goals are very important. If you see what is patient safety is nothing but to give a error prevention and to save the patients from the adverse effect associated with the healthcare. In healthcare, it is not only we are curing the patient, as the previous speaker have told, that any drug is not safe for the patient. Safe is only our healthcare professions. So this is a very crucial stage where we are keeping ourselves, we are stepping up and we are keeping the patient safe with our critical thinking and our scientific methods. If you see who have given the International Patient Safety Goal, as it is an international, so it is given by the JCI. They have told what? They have given a set of guidelines to promote the patient safety and prevent the medical error in the healthcare organization in worldwide. So if you see this symbol, this is the Patient Safety Day symbol. If you see the domains of quality, everything related to patient safety is basically quality based. We have to improve the quality, so we have to improve the patient safety also. It is safety, effectiveness, patient centricity, timeliness. We need to reduce the gap between the patient when patient is coming with the problem and when we are giving the delivering the care of the patient. Efficiency and equity. So why we need the patient safety goal? As I have told, to promote the specific improvement of the patient safety, and it will help us to create the evidence. It will help us to create the evidence to practice among the patients, and solution. It will give us the solution of the problems of patients. So as per JCI, what they have given the first goal as identify the patient correctly. Second goal they have given improve effective communication. Third goal they have given improve the safety. Am I audible?
Yes, ma'am, you're audible.
Okay, thank you. So and the fourth one is ensuring safe surgery. Fifth one is it's completely with HAI prevention, and sixth one is reduction of patient injury resulting from fall. So if you see identification, it is a very basic, but the most important factor in the patient safety. Because if I am not matching the patient's ID, if I am not matching the patient with the correct drug, with the correct procedure, then there is a safety failure and patient may lead up to in a hazardous situation like wrong surgery, wrong medication, wrong procedure, wrong treatment. So the main thing what the JCI have given, at least two identifiers we require to identify the patient. The first identifier is UHID or someone tells MRN number. It will be the unique hospital identification number based on the patient. The hospital will give the number. Apart from that, patient's name. Identifying by the patient's name and UHID is the best thing we can do. Apart from that, the hospital, if it is an inpatient, there will be other IDs like IP number. IP number is nothing but the course of admission, the number of course of admission. The UHID may remain same for a patient in a particular hospital, but the IP number with multiple admissions, it will change for the patient. And we always put the wristband over the patient. So when we need to identify, basically we see every time when we are doing something with the patient. It can be before giving medication, before doing any blood specimen, collecting any blood specimen or any other sample specimen collection. Then before taking the sample in clinical testing, before providing any kind of treatment, procedure, surgery or investigation, before giving the food and before discharge or at the time of discharge. Food we sometimes we forget, maybe medication you tell, specimen collection you tell, these things we always remember, but food we forget. But this is also a very important aspect because I can't give a non-vegetarian diet to a vegetarian diet, person. Then if a person is diabetic, I can't give them a normal diet. I have to give the person a diabetic diet. So in the food also, leveling is very important. And the main part, which we forget, we maybe with the flow, it comes with us. But I have seen actually, so patient's room number and location cannot be used as the patient's identification. So I'll just share one story what I faced in my hospital during my hospital courses. One medication error happened just for identifying the patient with the bed number. Instead of the patient was a pediatric patient and it was a general ward. So maybe some 11 room number B bed requests without identifying the patient with the name or UHID, with the wristband, with the mother or the parent, the staff have given with the bed number just connected. So instead of the B patient, the staff have connected with the C patient and medication error happened in this way. So identification properly is the best way to prevent multiple errors. So in case of when we need to remove the ID ones, only at the time of discharge we can remove when everything is completed for the patient. Patient is ready to go. No medication is pending or no investigation is pending. No, nothing is pending. Even billing also not pending. So that time only we can remove the ID band from the patient. If there is any ID band missing, so just raise the incident because ID band is a very important asset for the patient. So raise the incident and replace it immediately so that it will not be misused. In case of like some surgeries are there, maybe any limb surgery. So in the hand patient required the surgery, so ID band need to be removed. That time keep the ID band in proper site or replace the ID band with another limb. Maybe the ID band was in right hand, so place it in the left hand or the leg. Immediately, if it is not possible, keep nearby and replace it immediately. If we see the next goal, that is the improved communication, because communication is the very crucial part of a healthcare sector. Everything from the beginning, when the patient comes to the ER or OPD, we ask what happened. This what happened. If we don't ask and patient does not tell actually what happened, we will not able to progress the patient's treatment. Along with the nurse, the doctor, the radiotherapist, each and everyone require effective communication. So what JCI tells, hospitals should develop a proper process for verbal and telephonic communication, because in this era, telephonic communication is very important. Every time we will not get the particular clinician in the department. So we need to call them and we need to ask what is there. We need to develop and implement a reporting system, proper reporting system for the critical values and diagnostic test. Critical values like basic values, hemoglobin, the ABG reports, the electrolyte values of the patients. So these have the critical results for the patient's values. So how the hospital is implementing the communication of the critical values. If it's the next, what JCI is telling, proper handover process. These are actually given for the nurses because the shift handover need to be done properly. So proper handover process need to be followed. So for that, what they have given, different kind of tools they have given. If you see first, the handover process is the ISBAR or SBAR. ISBAR is nothing but introduction of the patient. As I have told previously, identification of the patient is very important. Whether it is a verbal or it is a direct communication, it is a telephonic communication, it is a handover process, whatever it is. So their introduction is a very important for the patient side. So what is the patient name, under which doctor, which bed number, what is the diagnosis we can inform in identification. Situation for what the patient I'm calling now, or what is the current problem with the patient. If I am calling and telling that a patient is having such problem, maybe a patient just in a general word with UTI. So maybe patient is having distended bladder, patient is having burning micturition, patient is having fever. So I'm just calling the consultant for reporting this event. So I have to introduce the patient first, that your so and so patient is there and patient is suffering from this and this. These are the clinical symptoms patient is suffering from. Then it will come to background. Background is basically for what patient admitted or previous history. Maybe patient is hypertensive, maybe patient is diabetes, having diabetes, maybe patient is having arthritis, relevant to that particular situation, what is required. After that, assessment. So I have assessed the patient. I have checked the patient's abdomen is distended. Patient is having 101 fever. Patient is not able to micturate. So I have assessed all those things. I will give my assessment to the patient, to the clinician. And at the end, if I am completely okay with everything, I am keeping everything, all the puzzles together, and I can tell that maybe it is a UTI, I will tell obviously, maybe it is a UTI. Do you recommend to give some antibiotic or something? If I am not okay, I will not ask. I will just ask for their recommendation. And obviously, the feedback, communication feedback is always give and take. Right? Communication is a process that I am giving the information to you. You are giving the feedback to me. The feedback is very important. That is the recommendation. Then if you see the critical values, if you see, verbal order, if you see, the verbal order is not when the round is happening and the doctor is prescribing, like give paracetamol 1 gram IV to the patient. It is not a verbal order because that is not an emergency situation. We can't take it as a verbal order. A verbal order will be only during a emergency situation like a code review. So in that case, maybe the physicians will be completely busy to make the recovery of the patient. So we will take verbal order in that particular emergency situation. And during this emergency situation, whenever any kind of verbal order will be given, that time this repeat back policy is very important, because if someone is telling give atropine 2 mg or give KCL 3.5 for KCL correction for this patient, I need to repeat it back for reducing my medication error. I should not give more, I should not give less. I should give them the correct route or to the patient. Just in ER, one recent problem happened for us. That is, Aspirin IV also I can give, nebulization also I can give. The doctor have asked the staff to give aspirin as nebulization, but she have missed it and given as IV. But immediately she realized and she stopped. So if this situation would have been prevented by repeating back. If she have repeated that aspirin IV, then maybe the doctor corrected the same that no, it is nebulization. So this repeat back policy is very important. And telephonic communication, as I told, is the best way to do the telephonic communication. So first, listen properly, write it down. We always forget to keep a writing pad with us and note one that we have enough memory, but actually this is not the correct thing. We should always keep a notepad and we need to write what the information is given to us. Whether it can be by the clinician, it can be by the another department nurse, it can be by the pharmacy, it can be by from the lab, anywhere, interdepartment, anywhere it can be. And always read back the message. Reading back in a verbal communication, whether it is telephonic or it is a emergency situation verbal communication, read back is the best way to prevent the errors. And confirm. Once you will read back, the confirmation automatically will happen. Now, in case of telephonic drug order, so telephonic drug order, all drugs we can't give. The hospital need to make their own policy for a verbal order or telephonic order. So narcotics cannot be given as a telephonic order. Narcotic can be given as verbal order, but narcotic cannot be given as a telephonic order. And when the telephonic order is happening, that time, within 24 hours, the physician need to complete the sign the drug card. The reconciliation of the medication should be done within 24 hours, not more than 24 hours. Then improve. I think this is out. Improve the safety of high alert medication is the third goal given by JCI. So in this, what they have told, the hospital must develop and implement a process to improve the safety of high alert medications. Lookalike, the safety of lookalike and sound-alike medication, that is LASA drugs, and it should develop a proper safe use of concentrated electrolytes, because those all the drugs will come under the high alert medications. So in the first, what is a high alert medication? We usually use this a pinch. So a pinch is basically antimicrobial drugs, P for potassium and other concentrated electrolytes, I for insulin and oral hypoglycemic agents, N for narcotics, opioids and sedatives, C for chemotherapeutic agents, H for heparin and other anticoagulants and thrombolytics. And if I'm seeing other drugs, those will come like neuromuscular blocker agent will be there, antipsychotic drugs will be there, then inotropes will be there, antiarrhythmic drug will be there, then basic inotropes will come under the high alert medication. So most of the hospital, what they are doing, they will keep this high alert drug as in lock and key, and they will give a separate cupboard for the patient for this drugs with the separate stickers. Usually, what I have seen in multiple hospitals, they will give the red color stickers for the patient for a visual indicator that it is high alert medication. I need to use this wisely. And double check is very important for this medications. Look alike, sound alike. If I'm saying this, all vials are looking alike. Those are looking same color, same cap, same size, but the compositions are different. Sound alike is also same, like atropine. So in this look-alike and sound-alike cases, what we are supposed to do, the visual indicator works the best in this look-alike and sound-alike cases, and giving separate cupboard is the best thing we can do. So in this case, Tallman later we can use for look-alike and sound-alike patient, which is given in the we can get in the internet. If you have separate thing in your department, which is included in your HIS, then you can give it as your own color codes. Usually, I have seen that fluorescent green and that fluorescent pink color have given for this kind of medication. And medication safety policies need to be maintained across the hospital, irrespective of ward, OPD, or pharmacy or central pharmacy. Wherever lookalike and sound alike drugs are kept, they should be kept in tall man letter in separate cupboard with the particular sticker, color coded sticker. And electrolytes, if we see, high concentrated electrolytes are a high risk drug, as we have seen. So those should not be given directly to the patient. Diluted form we need to give. The hospital should maintain a proper inventory, proper process, proper diluting process, SOPs for this patient, for this kind of drug. It can be kept in the lock and key, and this medicines can be kept in separate box. Always the highly electrolyte medication should be kept in separate box, not together, and highlighted sticker should be kept. If you see the ensure patient surgery, safe surgery, so it is a very big issue that wrong surgery to the wrong patient or wrong site is happening. So the basic thing is ensuring correct site to the correct procedure and correct procedure to the correct patient, and patient should get a proper surgery. For that only, WHO have developed a tool that is called patient safety tool checklist. Sorry. So here they have given 3 columns. In the first column, if you see, that is before induction of the anesthesia. This is time in. This is called time in. So during this time, the nurse and the anesthetist will read this entire thing properly. They will check. It is that they will identify the patient with name, UHID, under which doctor, from which ward the patient came. They will check whether the site is marked. The site marking will always done by the surgeons only. The patient require anesthesia, proper anesthesia checkup, have completed, TAC have completed. Pulse oximeter is there on the patients or not, and it is functioning or not. Patient is having known allergy, case of allergy, patient is having difficult airway or any aspiration risk, and there is more a risk of more than 500 blood loss. Because if we will run through this, we will identify what may require to the patient. Maybe a patient requires only spinal anesthesia, but patient is having a distress. Maybe patient require a general anesthesia at that time. You need to switch the patient to general anesthesia. How much blood loss? If I know how much blood loss is there, I will be prepared for the supplement to the patient. So then this is the before incision, skin incision. Once this time in is ready, then we will move to sign in. So in sign in, it will be nurse, anesthetist, and surgeon. All 3 team members should be there. So confirmation, everyone's name, because no one should be unknown to anyone in the particular team, because surgery is not individual's work. Surgery is a teamwork. So everyone need to understand who is doing what. It should be very specific. The procedure name, patient's name, again, patient's identification need to be done. Prophylactic antibiotic required and given before 60 minutes, or if it is not applicable, then will not keep not applicable. Then critical events. For surgeons, there is separate. For anesthetists, there is separate. And for nursing team, there is separate. And in case of like ortho or some surgeries are there where we require the images, MRI or X-ray, all images in neuro cases. So these are applicable or not. If applicable, it need to be displayed on the board. And after that, it will come at the end when the closure already happens. Patient is about to leave, before leaving the operating room, before wheel out. That time we need to do time out. In time out, what it is the nurses think that the nurse is confirming the patient's name and procedure again in all three states. If we see all 3 states, patient's identification is very important. Here, the complete instrument count, swab, needle counts are required. Specimens, if it is specimen is there, that is labeled properly or not, or if any solution required, that is kept properly or not. that we need to see, and any other equipment during this entire event, entire course of surgery. If there is any equipment breakdown or equipment problem is there, that is addressed or not. If addressed, obviously yes. If not addressed, then again it need to be written properly. To the surgeon anesthetist, what is the key concern of recovery management? So this is basically the post of one brief of the patients. And this all things should be signed by the particular stakeholders like the anesthetist, the nurse, and the surgeon. Everyone should be the stakeholder of the proper this entire checklist. Then it will come to reduction of the healthcare associated infection. If you see the most of the cases of like complicated cases, when complication it is going or patient's prognosis is coming down, patients will have this tendency to get infection. Patient will be more prone to get infection, whether it will be 40, it can be VAP, it can be Clapsy, it can be VAE, whatever it is, it can be sepsis, anything it can be, but patient will be more prone to get. Apart from that, a healthy patient also can get HAI. If we will just miss one thing, that is the hand hygiene. So in the basic concept of prevention healthcare associated infection, 80% we can gain through hand hygiene only. So the hospital need to adopt a proper guideline for hand hygiene and accept it. They have to continuously implement a proper hand hygiene program, and policies should be developed according to this HAI prevention. So if you see hand hygiene, WHO have given a beautiful hand hygiene poster, and they have given the hand hygiene poster, the process, how the hand hygiene need to be done. It's not only taking a little soap and water and just wash your hand. The proper steps, 7 steps, 11 steps, every step should need to be performed. And they have given a beautiful picture of this moments of hand hygiene. 5 moments. This we call 5 moments of truth. Because if you follow this, the patient will be safe. You are making the patient safe always. So this basic things need, if you follow this basic thing, irrespective of anyone, irrespective of nurses, irrespective of doctors, maybe lab technicians, maybe radiology technician, maybe housekeeping also, dietitians, the PCCs, each and everyone is responsible to prevent the patient's infection. And if you check these 5 moments, the patient, obviously we will reduce the risk for infection always. Then 7 prevention strategies, if we see. So from the beginning, if we see, the base is always hand hygiene. Then environmental hygiene, screening and cohorting patient. If there is any infected case you are identified. Surveillance, surveillance. So you will have your ICN, your HICC committee. So in that, you will have your ICN, you will have your link nurses who will continuously do this surveillance audits basically. Antibiotic stewardship program, it will be done with the microbiologist and following guidelines. So we need to adapt some guidelines. It can be from WHO, it can be from CDC. They will give the guidelines and we can modify. Some guidelines are there which we can modify a little bit. So according to your scenario, you think, do the extra for the patients. And safety. Next is reducing the risk for patient harm resulting by fall. Fall is a very important and very big safety issue for a patient. Just think, I came to treat, maybe I am having a viral fever and I was not able to take my care of myself, or my family is not there. I just came to hospital for my recovery and I end up in a fall. And ultimately what happened, I had a head injury. So I came just to treat myself with a viral infection. And it lead me to head injury, which meant like I will be in coma for like 3 months. I may require a surgery, a craniotomy. Maybe nothing is there. Just I had a fracture, leg fracture. Maybe for that fall, my hospital stay increased more than 7 days, 8 days, 10 days, 14 days. So ultimately, the patient is the suffer in case of the fall. And we are the person who can prevent fall very easily. So first thing what we need to do, training the patient and patient family. Because as we see, fall happens when we will not push the patient. We will not push any patient that, okay, I'll push and you will fall. So basically, patients education and patients understanding, patients families understanding. I may think I don't have anything, I am okay to go now. But I need to understand the nurse or the doctor or the PCC, whoever it is, the counselor, whoever it is there. They need to make me understand that why I should not get up so fast. I may get a headache. I may get a dizziness. How I can use the call bell when I should expect this medicine is about to finish. I should not go along with the. I will stand to the washroom. Why my anti-sleepers are very important. Why the bed light is very important for me. Then do not leave the patient to the not leaving the bed without any help. So I may be very good, I may be an athlete, but in hospital I am a patient. So I need an assistant. Either it can be family. It's very good to involve the family member and teach the family member how to take care of the patient. Is the best thing to do because it will reduce the burden among the healthcare workers. And if it is really required, you need to go, obviously. So that time, you just instruct the patient, don't leave the bed without me. Fall risk assessment, until I am assessing the patient is having risk for fall or not, I can plan my activities to prevent the fall. So fall risk assessment, what we are using, John Hopkins fall risk assessment for adults and Humpty Dumpty for the pediatric cases. It is a very beautiful scale. It's very subjective to the patients. We can identify the medications. We can identify the patient had any fall or not. It's age specific also. And equipments required, cognition level, mobility, each and everything is there. So it is a very beautiful scale we are using there. According to that, again, we have to plan. Hourly rounds is very important for the patients because when we will go for hourly round, ultimately the needs of the patients will met. I have started one IV maybe which need to go for 2 hours. Now, patient will have urgency for that. So if I am going hourly round, I am asking whether you are having pain, whether you are having any elimination need, whether you need anything like water or you need any food, whether you need the TV remote, a basic thing. Very simple thing, TV remote. If the surrounding is okay, surrounding is safe. Maybe some people came, did physiotherapy or something and came out from the room. The room is arranged properly. We can identify all those things by only hourly rounds. So hourly rounds, just meet with the patient, ask this 5-6 questions and come out. Patient's need will be met and patient's fall risk will be reduced. Bed height should be fixed low because I will not jump from the bed. Obviously, if I'm jumping, I will fall down. And the side rails are very important. The side rails should be up always for this patients, especially for any surgery patient who came just after surgery. So put a side rail and shift the patient from the stretcher to bed. Then unused equipment need to be moved from the room. So basically, you need to make the room tidy. The room should be neat and tidy, and things should be near to the patient and proper lighting. If light is well, there will be very less chance for falling to the fall for the patient. And some fall signs we can use that like now here this is the slippery area or this is the little downwards area or the mopping is happening. So just put the caution board, wet floor. It is a visual indicator. Some hospitals have used this fall risk band like ID band. The patient is having fall risk band that I can fall risk assessment we have done. So from that only I can understand that yes, this patient is having high, this patient is having moderate, this patient is having low fall risk. So here I will give the patient as a fall risk, or in the bed also I can keep a visual indicator that patient is having more fall risk, or maybe fall risk is moderate or low, but patient is too much agitated or too much patient is not willing to listen to you. So that time we can put the tags according to our assessment. And it is always please call before fall. So if you see the goals, the first summarize of the full goals. So first we identify the patient correctly, improve effective communication, improve the patient's medication safety, and ensure safe surgery to the safe patient, reduce the risk for healthcare associated infection and prevention of fall. Now this complete thing is given by JCI. JCI is an international organization. Now if we come to India, an Indian scenario, we will get, rather than this parameters, some parameters are also there, like safe use of devices. HAPU, very simple HAPU, which is very common in the hospitals, long stay patients. So we can include and we can make our own patient safety goal. Instead of the international, whatever given, we can make our own patient safety goal according to my indicators, my previous year's data. Like previously it was told, we are always following the Western culture. So JCI is also given by the Westerns. But our scenario, our patients, our people are completely different. Our attitude, our cognition, our genetic, everything is different. So according to our story, we need to make the script. Very simple it is. So the script is basically we can modify our patient safety goals there. So if you see in my hospital, we have 10 patient safety goals. These are 4. In this 4, we divided like medication safety in 2, 3, and we included lines, safety of the lines and tubing. We included prevention of hospital acquired pressure ulcer in this. So as per your requirement, it's always good to include more goals. So that is my session today. Any questions? Any questions? If nothing is there, then I'm good to go. Yeah. Sorry, I can't hear you. Something was telling, right? I actually am not able to hear. Maybe in chat box also I can't see any questions. So I think the session is over. Thank you so much. Thank you so much, June, for this wonderful opportunity. Thank you. Bye.
Thank you, ma'am, for your valuable words.
Microphone on. Now let's delve into the innovative concept of a green hospital where substantiality meets healthcare. Let's discover how these eco-friendly initiatives not only benefit environment, but simultaneously promote efficient healthcare practices. With this, I would like to call upon Dr. Jeet Patwari, sir, to share his expertise on green hospital concept.
Please allow me to share my screen. It's visible.
Yes, sir.
Yeah. Can I start?
Yes, sir. Yes, sir.
So after the clinical sessions, we come to a completely different zone actually, where we would be, discussing about green hospitals. Myself, Dr. G. Patwari. I'm from Guwahati. I represent Pinnacle Healthcare Consultants in Guwahati. The allotted time was 11:25 to 11:55. After that, I thought we will have some question and answers. Am I audible and my screen visible?
Yes, sir.
Yeah, please feel free to interrupt if at all any of these are not okay. And then this is a completely different kind of subject where I'll try to keep it as simple as possible. Now, when we talk about, yes. Yes, ma'am?
No, no, sir, it's not an issue. Please continue.
Oh, okay, fine. So this is the scenario in most of the cities. We have unplanned buildings and we see a purely concrete jungle. The best picture that we get when we, take off, the flight takes off from a city and before it lands in another airport, your destination airport, we get to see a lot of these concrete jungles. And this is something which has affected the entire environment that we live in. Now, what are the environmental challenges that we face? Before directly going to the green hospitals, let me take you through a few other topics, subtopics, I would say, or related topics, and then it would be easy for everybody to understand. So this is the global warming, and then the sewage that is thrown or disposed into the water bodies. Then the waste management, which is not there. Then the fourth one is the deforestation, where the fifth one is the entire landscape has changed, and the ecological and the biological environment. If you look at the biodiversity, so that has changed over a period of time. We have seen the increase in the temperature, the global warming, and the recently, in the last maybe a couple of weeks, we see in the newspapers or in the news that the highest recorded temperature in this city or the other city, the highest temperature today is in this city. So these are the concern, the topics which actually need to be addressed. And with that, we have, become dependent on few things like the energy. Without energy, we cannot run. Maybe whether it's coal, whether it's fuel, whether it is solar energy, whether it's natural gas, oil, fuel. But all these would have some sort of reserve, and that is going to deplete over a period of time. And that is the reason why people have, tried to use alternate ways where the people have tried to utilize the solar energy, the wind, the hydro energy, the biomass, and others. The environmental challenges in the hospital that we have is, number one, high energy consumption. So if you look at, just a second. If we look at the high energy consumption is because of this 24/7 operations. We cannot shut down the hospital, and energy intensive equipment, whether we call especially the ICUs and the radiology, the OTs, and systems for heating, cooling, ventilation, and medical machinery. This leads to large carbon footprints and high operational costs. The waste management. Now, when we talk about green hospitals, the first thing that comes to our mind is that whether the hospital is or has adopted the energy conservation practices. In that case, what we do is, what is the total bill? We have replaced the old bulb and the tube lights with the CFL, and then over a period of time, we have replaced it with the LED, low consumption LED illuminations or the lights. But if you look at many hospitals, especially in the smaller towns and cities, they still do not have a proper waste management. They do not have any recycling of the energy or the resources. I did assessment of many hospitals across Northeast, and I found that the effluent which comes out from the laboratories, from the ICUs, from the OTs, the wards, are directly disposed to the common public drain. They do not have an effluent treatment plant to treat the effluent or the water, the liquid, before being disposed to the public drain. Now, this leads to a high carbon footprint, and also because this is not recycled, it also leads to a high operational cost. Now, we talk about carbon footprint, but if at all we look at these kind of waste management practices will, in fact, lead to creation of or production of gases like methane, which is, more toxic to the environment and also to the atmosphere. But we do not have any proper measures that can be adopted in that. Now, when we talk about the waste management, when we talk about waste management in the hospital, the first thing that comes is the biomedical waste management, whether the areas or whether the items or the waste generated in the OTs, ICUs, the wards are disposed properly according to the color-coded bins. But there are other wastes also which are equally dangerous, like the electronic wastes. Do we have a proper disposal practice? We do not. And even for the biomedical waste management, we do not follow the state pollution control board norms and the central CPCB, the Central Pollution Control Board norms. Then water usage and management, these are challenges because hospitals consume a huge amount of water daily for the sanitation, number one, for the medical processes and the facility operations. When we talk about the MEPs, the mechanical, electrical, plumbing, there also we use a lot of water. Now, we talk about the HVAC, the heating, ventilation, and air conditioning, where we use the chillers and the larger hospitals. We always prefer water-cooled chillers because that is economically viable, and that is where we use a lot of water daily in the hospital. Now, efficient water management is necessary, and a little bit of, if at all you can recycle, that is going to add to your benefits. Then the chemical use, we use a lot of reagents for the labs. We use a lot of chemical agents in the ICUs, that is the medicines, the consumables. We use a lot of cleaning agents, which are actually toxic to the environment. And that is the reason why, whether we manage these chemicals without harming the environment, whether we do that or directly dispose it off in the public drain. Then air quality, indoor air quality needs to be strictly controlled in healthcare settings. Now, what are the parameters that need to be considered? Now, we cannot use a normal or natural air directly into the patient wards, especially in the ICUs and the OTs. We cannot do that. Now, air quality in the OT has to be controlled, the filtered and the relative parameters need to be taken care of, and then only you can use it in the OTs. Now, however, maintaining high air quality can be resource intensive, because if at all we have to use high air quality, that needs to be, filtered through the air handling unit, number one, then your HEPA filters, and then only it can be pushed to the OT. Building and facility impact. Many healthcare facilities are housed in older buildings that may not be energy efficient. Now, many times what happens is the hospitals are set up in a existing building, maybe a hotel, maybe an apartment, maybe some other facilities which are converted to a hospital. Now, in this case, this might not be energy efficient because the entire MEP drawings or the installations are already there. What you can do is a little bit of, upgradation, and then we can use it for hospitals. Resource intensity of medical supplies, that is disposal of single-use medical supplies like gloves, gowns, masks. Now, these are directly disposed at times because we do not train the waste handlers. We train the doctors, we train the nurses, train the technicians how to dispose it off in the different color-coded bins. But have we ever done a training program for the waste handlers? No. If you follow them, what they will do is many a times you'll see they will mix the containers or the contents of one container with a common container. So that is where things need to be, you have to be very, very alarmed. Then the transportation of goods, I'll just skip this. Now, environmental challenges faced by hospitals. Again, this is something which a World Bank report had submitted, or it was found out that energy consumption highest is the electricity that contributes to 91%. The fuel, that is from the generators and the other machines, say for the fire pumps and other things. Fire pumps is not used regularly, but for the brands, you definitely have to use it at times. Then from the kitchen appliances, we have to use LPG, so that contributes to 3%. Now, if at all we look at the other aspects, energy consumption cost, electricity contributes to 95%, fuel and oil contributes to 3%, and LPG, the remaining 2%. Now, what is a green hospital? The definition says that it is defined as a hospital that has taken the initiative to do or more of one or more of the following. That is, think green during construction and keeps the greening process going on. This is something which is very, very rare because we do not think about the green concept at the time of designing and at the time of construction. We will discuss later. A green hospital is constructed around a facility that recycles, this is important, rescues materials and reduces waste and produces cleaner air, reduces CO2 generation, that is the carbon footprint. Then choose an environmentally friendly site. Your site of the or location of the hospital is also very, very important. Utilizes sustainable and energy efficient designs, uses green building materials and products. What are these materials and products? We will discuss later. Now, energy efficiency. Hospitals consume, this I've already discussed. Water efficiency, that is from the efficient sterilization processes and reduce water usage further. Recycling is something which is done. When we design the MEPs, what we do is we recycle the water from the sewage treatment plant. The technology is such that from the sewage treatment plant, you can use it and filter it, process it, and you can use it as a drinking water also. But because of the social taboo, we do not do that. What we do is we create a double line plumbing systems where we use it for flushing in the toilets, and another part is in the gardening and the other things that we can use. Now, indoor air environment, maintaining high indoor air quality. Now, there are set parameters set by the NAB, especially for the OTs, in terms of the air. That is, the air should be, the temperature of the air should be in the super specialty OT, 18 to 28 degrees centigrade. In the normal general OTs, it should be somewhere around 20 from 20 to 22 degrees centigrade. The relative humidity should be somewhere around 50%. Your particle count should be as per ISO 14644 guidelines, where at the table it should be class 10, at the level of the doors, and near the door it is somewhere in class 100, and so on. The exchange of air in the OT is also defined, and that is how it works. Now, in doing that, the HVAC systems has to be very strong. Now, this is one component which uses a lot of energy and also increases the carbon footprint in the hospital. This is something where the image shows the use of natural light, where you are trying to reduce the energy consumption. Waste management and sustainable landscape, something like this, where it takes care of the quality of air and also the environment. Now, green hospital construction, how we construct a green hospital. The first thing that comes is the HVAC system being upgraded to less energy. Earlier, what we had was those window ACs. which used to emit a lot of sound, and also energy efficiency was not there. Then came the split ACs. Then came the chillers, and again, there are two types of chillers. One is air-cooled and the other one is water-cooled. Now we have VRF, variable refrigerant flow systems. Now, these are energy efficient devices. When we buy this, when we buy the domestic air conditioners, we always look at the star ratings. Even for the chillers and the other things, we do have that kind of systems in place. We purchase equipment that has an energy star rating when available. When we buy a radiology equipment, we also look at the load that we have to connect it to. So that also is some factor. Retrofit lighting, we replace old lighting fixtures with ones that use less energy. Building management system, our buildings talk to a central control system, which helps us to use less energy. Now, BMS or IBMS, in a building management system or integrated building management system, is something where, it is a computer system which connects all the facilities in the hospital to a central server. And from the server, you can control the entire environment. Suppose the OT is running, but it's not being used by anybody. So from the BMS only, you can control the temperature, you can switch it off, you can switch it on, and like the way you want, you can control the entire system. Then the lamps, we purchase efficient lamps that has low environment impact on the environment. That is why the CFL and the earlier tubes have been replaced by LEDs. Design your building renovation and design incorporate energy conservation principles. Then data tracking. Have you ever done an audit? When we talk about audit, we always end up doing the financial audit. Now, after the NABH and the quality management system practices have come, we have started doing the different clinical audits. We have done the management audits. We have done other audits also. But if you look at the data tracking of the energy efficiency, the entire system will come up. And you take my words, you will be able to save at least 5 to 10% on the energy savings. Then the team awareness, we raise the awareness about our employees how to save energy. Many a times we see when we enter a hospital room or maybe in the conference rooms, we see the lights and the ACs and all things are on and nobody is there. So people have come up with, training all those, and they stick some stickers. Have we switched off the light and the fans before leaving the room? So something like that can be done, or people are doing it. Again, the best practice is to, if at all you can afford, use the sensors where the moment you leave the room, it will automatically get shut down. Operating rooms, we design our ORs to optimize energy and outfit them with LED operating room lights. Now, materials for green buildings. What are the materials that we use? Say, for example, we talk about rainwater harvesting. Have we actually done it? Most of the hospitals, they have some, pipes and other things, and that is not connected to the deep borewell or whatever, the water source. That is directly drained into the main public drain. That is not rainwater harvesting. So we start from rainwater pipes, then the solar panels are there, then high SRF pavers, these pavers are basically temperature resistant. Resistant in the sense it will prevent the external heat to get inside. So it will prevent the internal environment to get, the temperature not to rise beyond the point, and that will have some savings on the air conditioning, eventually into the electricity bill. Then again, the cooling towers are there for the HVACs. Skylights are there. That is for the use of natural lighting, where you have some atrium kind of this thing where we have natural lights. Then many people use roof garden. This is a good practice if at all you can use it. Then the recessed windows, double glazed windows, insulated walls. These are the materials which can be used. Now, what are the benefits? If we are talking about green hospitals, everybody is promoting that we should go for green hospital. Definitely, there should be some sort of benefit for the green hospitals. The one is economic benefit, reduced operating cost. This is something which many people would find it a bit peculiar, but it is. energy efficient systems will and sustainable water practices reduce utility costs over time. It's not in a month's time or a couple of months' time, but it will definitely reduce your operating cost. Enhanced asset and marketability. Now people understand, the educated lot understand the benefit of green buildings, and they have high market values and attract more investors and funding opportunities. And eligibility of incentives, a lot of tax incentives, grants and rebates are there for the energy conservation and the other things from the government. Reduce environmental footprint, lower the emissions for greenhouse gases. That is one, we are contributing to the environment. Then conservation of resources using materials which are more efficiently, such as water recycling. We are, not dependent on solely on one water source for water. You are recycling it and also decreasing the overall water daily requirement in the hospital. Then health and safety environment, improved indoor air quality, utilizing non-toxic materials and advanced air filtration system. I have already discussed this for the OTs. And there are a lot of filters which reduces airborne pollutants and lower risk of respiratory issues and overall patient and staff health. Better patient outcome because of factor number one. Because of this, definitely it would have some impact on the patient outcome. Also, increased access to the natural light can lead to faster recovery rates. And this is shown in one of the studies where they had compared two hospitals, one with without natural light and natural air, natural ventilation, and the second one is with natural light, where the patient from the bed he or she can see the external environment. With the same sort of cluster of patients, they had done the study, and it was shown that the hospital with the natural light and air had a better recovery rate for the patients. Reduced infection rates, effective waste disposal, and reduced chemical. This can help to minimize the potential sources of infection. Now, social benefits. Again, work environments with good natural lighting, air quality, and lower noise can improve staff morale and productivity. I used to work in a hospital in Delhi where the administrative office was in the basement. When we entered, it was like, we have entered the box with no natural light or ventilation, nothing. So that led to, a little bit of mental block or mental fatigue at the end of the day. That also affects the productivity of the staff. Now, community leadership, I'll skip this. Educational opportunities. By integrating sustainable practices, hospital can offer educational opportunities for staff and patients about the importance of environmental health, promoting widespread community engagement and awareness. Now, this is something we have implemented. The management has implemented these practices, but have not. The management members the directors have not trained the staff and the other people. It is not going to help. You should help and educate the staff and the patients also regarding the importance of environmental health and promoting widespread engagement and awareness. Now, what are the challenges? The number one challenge is capital investment. Now, in the smaller, especially in the smaller cities, the B-class cities, where suppose if somebody wants to set up a hospital, the initial thing that they would look at is the project cost or the capital expenditure. Going for a green hospital, definitely the upfront cost is on the higher side because we are going to utilize updated technology. We are going to use materials which are a little bit costly. And the ROI, return on investment timelines, it takes time to see a return on investment. This is one. But if you look at the long-term benefit, this is going to help the promoters to have better ROI. Then the building codes, local and international building codes can limit the use of innovative green technologies. Now, suppose we want to have green building. Now, it would require slightly higher floor area than a normal building, normal hospital building. Now, if at all we have a defined coverage area, which is defined by the local municipal norms. Now, within that area, if at all we want to cover up the hospital, so the size of the hospital is going to be a little bit lesser because we have to leave space for installation of those materials for the green hospitals. Then the certificate processes, complexity and cost associated with obtaining green certification like LEED or GRIHA. We will discuss this later. Then the technical challenges, we have talked about this, but other people, especially in the metros, it is never a challenge like the way it is in the smaller towns and cities. We talk about green hospitals, but do we have that skill set or the manpower to install these kind of systems? Then again, the specialized knowledge and other things need to be there, and that has to be passed on to the staff which has to be used at a later date. Suppose we have installed some sort of system for the green building and the staff is not trained. So it is going to act like a normal hospital building only. So the staff has to be trained. And this is the skill gap which is there where, we really need to put our focus on. Stakeholders resistance, internal stakeholders. This is one of the major hurdles. Resistance from management and staff due to changes in the workflow and increased workload. This is one. Again, internal stakeholders from the shareholders, when the capital cost goes high and the return on investment is slow. So ROI, the break-even is going to be slightly longer. The people who have put in money, they would be more interested in getting the returns rather than contributing to something which is beneficial. So if at all I am investing something, I'm interested in investing in a venture which is going to give me better and quicker returns. So this is one of the resistance which is definitely there. Then the external shareholders includes challenges from patients, suppliers, and community who may not understand or support the green initiatives. Now, suppliers might not be aware as to what are the materials that need to be used, and the community also might not understand the concept. The maintenance is one of the concerns because if at all we use it like a normal building, that is not going to help. It has to be run as a green system, and that too should run efficiently. Regular updates and upgrades. These technologies are, they keep on changing, and we have to update and upgrade it over a period of time, which again adds to the cost. Financial viability, funding constraints can hinder the adoption of green practices. I've already discussed. Economic conditions, fluctuation in the economy can impact funding and operational cost. And now overcoming these challenges, how to do that? There are ways to finance green initiatives like green bonds or partnerships. There are organizations who would actually, promote this kind of green initiatives where you can partner, number one. Number two, there are a lot of tax benefits and the other things which are offered by the government. And then education and training, you have to educate all the stakeholders, that is internal, that is the doctors, nurses, technicians, whoever it is there, and about the benefits of green hospitals, and also the external people, that is the patient and the other people. Then leveraging technology, like say IoT's Internet of Things, will check how to minimize the cost. Now, future direction is advanced renewable energy integration. We have to integrate the different systems. When we plan the mechanical, electrical, plumbing, the MEP designs, it has to start from there. We do the local or we do a normal MEP design, and then after that, if at all we try to integrate at a later system, 5 to 10 years down the line, that is not going to help. So when you plan for a hospital, if at all you really want to go for the green certifications or green adoption of green practices, you have to plan it right from the beginning, and your planning should include the renewable energy integration right from the beginning. Number two, the smart hospitals where you use the Internet of Things, IoTs, which will optimize the energy, reduce the waste, improve efficiency. Then the biophilic design is expected to gain traction. It aims to improve patient recovery and well-being through increased connection to nature using features like indoor gardens, natural lighting, and use of natural materials. In one of the hospitals that we designed, we created a part of the floor into a natural garden. From the corridors that patient can directly walk in, they have a corridor where they can move on their The patient can be moved in a wheelchair. For the ambulatory patients, they can directly walk into the garden, and that actually, helped a lot of patients and increase the patient's satisfaction index also. Water reclamation and recycling, advanced systems for treating and reusing water on site will become more common. So this is to be done because everywhere we are facing the scarcity of water. Though the government has, given a lot of impetus on the supply of water, but at the end of the day, water is still a scarce resource. Zero waste policy. This is I have included it, but this seems to be near impossible in a country like India, where we are still using the plastics and the other non-biodegradable items. Then the green procurement policies, this has to be done from the management and the purchase department. Medical supplies to cafeteria, food, all are to be sourced in environmental, socially responsible ways. These are the areas where we should really put focus on. Then telemedicine and digital health advances, where we reduce the use of paper and the plastics. Plastics in the sense, maybe in the form of the films that are used for the radiology and the other areas. Then the sustainable building certifications, we will go into this lead for healthcare. We will go in the next. The policy recommendations, government incentives and subsidies. Without the help of the government initiatives, especially in the private healthcare, it is not that easy to establish a green hospital because the financial support has to be there because of the capital intensive, the projects and that is where the financial incentives from the government for the hospitals is very, very much required. I set up a green hospital until and unless it is certified by a recognized body. I cannot declare it as a green hospital. It has to be certified. Then the tax breaks offer tax reductions and exemptions because I'm contributing to the society, contributing to the environment. That kinds of incentives have to be there. The grants and retrofits allocate grants specifically for retrofitting older facilities with energy efficient systems. Then there should be some sort of regulatory framework that need to be designed. Mandatory green standards. Now, we are talking about LEED certification, which is going to be very, very high standard. But to begin with, we can set up few achievable mandatory green standards for the hospitals. This can be done by the government when we talk about the energy, the water, and the waste management and the indoor air quality. The minimum standards can be defined. NABH has come up in a big way, but NABH is an accrediting body. Accreditation is not a mandatory thing. It is a voluntary thing. So NABH cannot impose that you have to do this. Then the building codes, revise the national building codes, accreditation requirements. Then the public-private partnerships, encourage collaboration with the government. Then the innovation hubs. Then awareness and capacity building, where we have educational programs that train hospital administrators and facility managers on green hospital. Now, these are the people who actually, are the decision makers in the hospital. So they have to be well conversant with the various concepts of green hospitals, and then only they will be able to take decisions or initiatives in their respective hospitals. Then the public awareness campaigns, run public awareness campaigns regarding highlighting the benefits of green hospitals. And to both the environment and patient care, thereby increasing demand for sustainable healthcare services. Research and development that is still going on, but it is still in a very, very nascent stage in our country, where more impetus is given on the other aspects rather than going green. Now, data collection and analysis will show, but data collection and analysis will be possible if at all we maintain the data. Number one is this kind of number of these kind of hospitals is less, and also the data management is not there. Now, role of technology. May I know? Can I have another 2 to 3 minutes, ma'am?
Yes, sir.
Yes,
please.
sir.
Yes. So Internet of Things, these are devices, basically sensors or something like that, which are installed in the different areas, which can control things like HVAC and medical equipment. Smart sensors and automated system can significantly reduce energy waste. Now, water conservation, IoT can help monitor the water flow detection leaks. Many times we see that water is leaking from somewhere. Maybe there is an overflow. So those kind of practices will be, those kind of things can be prevented by use of IoTs. Waste management, smart bins equipped with sensors can monitor waste levels and can the composition facilitate more efficient waste collection and segregation. So many times what happens is there's an authorized body, authorized company or an organization which is allowed to, as per CPCB norms, which is allowed to collect the waste from a radius of say 120 kilometer radius. Now, what happens is when the hospital is located in the suburbs, the waste is collected maybe after 48 hours or within 48 hours. In that case, what happens is when we put the waste in the storage bin, especially the organic wastes, what happens is it decomposes and leads to a toxic production of this thing. So those are to be monitored. Those are to be monitored, and that will help you to keep a check on the toxic levels. Asset management, I'll skip this. Now, these are the two certifications which need to be considered. LEED is Leadership in Energy and Environmental Design. This is the gold standard, which is there, but very, very difficult to achieve. Now, our Indian this thing has designed this GRIHA, Green Rating for Integrated Habitat Assessment. There are 33 criteria with a score of 100. Now, there is another scope which is there for innovation score. So suppose you do some innovative, you have adopted some innovative ideas where, you are adding to the energy conservation and the green practices. So you will get a mark out of 4. So total score is 104. And from that, the guidelines, the certification is given. Now, the take-home message, what we do is, whatever we do in the hospital, at the end of the day, we are doing it mainly for the patient. But all activities, the doctor, nurses, paramedics, admin, whatever is there, the patient is at the center. So when a patient comes in, maybe for you or me, maybe he is just a patient. But for somebody, he is the sole breadwinner of the family. Maybe he is the father of a newly born child. Maybe the husband of a newly married lady. Maybe the only source of support for the old and ailing father. So when he walks in, give our level best in terms of the treatment. And also, this kind of practices would definitely add to his well-being and also the recovery. So give our best practices, give our best in terms of clinical and the non-clinical and the support services, so that when he walks back home, he goes with a smile. So let us take care of him like our own brother. There's no gender bias, though I have mentioned brother here, maybe brother or sister, definitely. So this is not by me. This is where Dr. Lilus also says the Associate General Superintendent of CMC Vellore. So thanks for your patient hearing. And namaskar, and these are my contact details if at all you want to get in touch with me later. Maybe we can take up a couple of questions if time permits. I have shared my presentation with the organizers, so you can take the presentation from there. If at all you have any doubts, you can definitely get in touch with me over mail or on my website.
Okay.
Thank you, sir, for sharing your knowledge with us. Thank you, sir.
Yeah, thank you.
Now, we will look into effective strategies aimed at mitigating medication error risk and ensuring higher standards of care with our next expert, Dr. Kapil Jirpe, sir. who will be shedding light upon the pressing concern of reducing medication errors and improving patient safety. So,
yeah, good afternoon. I will just share my slides and I will start it. Just few seconds. My slides are visible?
yes, sir.
Yes, sir. Your slides are visible.
Yeah, and sound is okay?
Yes, sir.
Okay, so good afternoon, and I must thank organizers for inviting me for such a very interesting lecture, because though I am a clinician, I'm concerned with the quality, and I always believe that every clinician should believe on a quality, because generally clinicians are hesitant to follow the NABH or any accreditation or any quality markers. They feel that their job is to just do the diagnosis and do the management. And other way around, I always feel that all of us work for the patient safety and its well-being. So quality is with patient-centric association. And if we maintain the quality, if we prevent certain errors in your day-to-day practice, it is related with the safety of the patient. And more the safe your patient, more will be the your career. So when I came across this, this was regarding the medication error. So if you see, there are almost, this was a few years back, but 7% of the patients suffer the significant medication error. We lot talk about the heart attack, IC bleed, and other complicated in ICUs and a hospital. But how many times we discuss about the medication error is of my concern. Almost 44 to 98,000 die because of the medication error. It's a huge number, and it was few years back. And most important thing, it was reported medication errors. There are so many errors are unreported, and mostly in India, we don't have that culture of report. We have a fear of the action, so we don't go by the reporting. So if I always feel that if we start reporting medication errors and these harms on a regular basis, it might be the eye opener for all of us. And the cost, it is not only the risk to the patient, it is a huge cost to the healthcare. And at that cost, we can do better with the rest of the things in healthcare system. So most important thing, we should remove from our mind that we are responsible for medication error. That means the doctors are responsible for, nurses are responsible. Healthcare is the only responsible for medication error. No, we should not blame the healthcare society or doctors or sisters. It's a system. Probably we failed to establish a safe system in our practice that might lead to that medication error and harm to the patient with the extra cost, rather than any individual or any group of the healthcare workers are responsible. So our system should be the safe. Our system should be the less harm to the patient. You will surprised to know, when I was just search last year regarding the one world medical error on the internet, and there are 1,57,000 results. I got it. It is reported. Most important thing, it must be the tip of the iceberg. So it is not rare. It is not unheard. We are probably ignoring this important aspect of the clinical management in our patient. One should know that the error is always human. We are humans. We are there to do error. The most important thing, how fast we recognize this and correct it, is more, rather than going for the hiding it. Second thing, healthcare is a complex system, and there are so many layers are there. There is a government, non-government, then we go by the hierarchy, and every system try to put a pressure on the their lower system. So it's a complex system, and we believe that entire system should work in a harmony, which is next to impossible. So we need to accept that healthcare in current healthcare system, with its complexity, the errors are going to happen. We need to find out. And medication errors are multifactorial. I told you now, suppose there is any medication error happen in my unit, that doctor or on-duty nurse is not responsible. Entire system is responsible. There are so many facets of that medication error. It's a multifactorial. You cannot just call that bedside sister and fire or punish her because she did something with the I always feel that who is behind that entire incidence. And focus should be fixing the complex medication system in which work. So I would like to correct the entire system rather than the individual. simple to understand. So errors are preventable. You need to be very proactive in picking up the errors. You involve the planning and ongoing efforts to reduce in future. So my objective of my talk is, I'm going to talk only for 25 minutes, differential between the different types of the medication error. We should at least know what type of the errors we are day-to-day coming across, know their common cause, why this happen, how to prevent them in future by doing some strategic management and communication with the rest of the system. So this was a very nicely depicted in this. So this entire events, whatever the happening in the ICUs and the hospitals are the medication misadventures. In medical misadventures, there are the adverse drug reactions, adverse drug events, and medication errors. So medical adventures is mix of the adverse drug reactions plus adverse drug events plus medication error. I am going to explain you with the help of the cases. So this was the first case. These are all true cases, real life cases, and I came across in last 10 years. This was a 67-year-old lady came with the CVA, admitted with the history of difficulty in breathing, fever, and deglutition difficulty. She was treated with the IV antibiotic, oxygen therapy, supportive treatment because she had aspiration. She improved in due course, and we decided to shift out. At the time of the discharge, the junior doctor came to me and said that, sir, I have just gone through her history, and she was allergic to the piperacillin tazobactam. So it was something which was very surprising because the patient was already on a piperacillin tazobactam for 7 days, and the patient was giving a history of the allergic to penicillin. So here we need to find out where things gone wrong, whether this is a ignorance, whether this is a error, because we have given a piperacillin tazobactam, but patient didn't have the reaction, but patient is giving a history. And when I gone through the history again with the patient was a matron, retired matron from the government hospital. She said that whenever she used to give piperacillin to the patient, she developed itching on her hand. So it was not actually the reaction. She had some feeling of the itching when she was giving the injection. The most important thing at the bottom line is the history. We in our day-to-day practice, we are so busy with the lines, catheter, and the decision making, we forgot the basic act of the history. And that is what we need to see. There are so many articles are there, how to prevent the drug-related death. What the prevalence of the drug-related death is 5.6, and 45% are the preventable deaths. So there is no excuse to the history. You have to spend a lot of time with the history, and don't forget to ask the history of the allergy. And even if they give a history of the allergy, please go into the depth whether it is a possible, sure, or there is a doubtful history. And if there's a doubtful history, just ruled out that. And that's a way. There are the even in accreditation process, it is very nicely elaborated how to find out whether patient is allergic, and rate whether it is there is no drug history, whether it is a possible, or whether it is a sure, or it is a confirmed. There are the categories of this thing. But bottom line, 5.6% of the drug reaction, 45% are the preventable deaths. Okay, now next part. Now, next part is regarding the adverse drug reaction. So this was a 35-year male admitted with the history of the road traffic accident. He was arrival unconscious, and he received the diclofenac sodium. So it's so common. Patient had a trauma, patient had a pain, on-duty EMS doctor gave him the diclofenac sodium. Patient had a severe anaphylactic reaction. BP was 60, heart rate was 160. He was hypoxic. Immediately, we noticed that this is a drug reaction. We had given him the adrenaline. We have given him the oxygen, fluids. He settled down. Now, issue is whether it was intended or non-intended, and that is what the you can say it is an adverse drug reaction. So adverse drug reactions can anything, but they can happen with your regular drug. They can happen first time in life. They can happen in the later part of the life. And there are so many evidences and so many papers are there. Even I have published in a IGCCM regarding the incidence of medication error in a critical care unit at the tertiary care hospital. What we need to understand the definitions, the adverse drug reaction. What is adverse drug reaction? They are always unintended, but they are more harmful. So they are unintended, unexpected, harmful events attributed to the use of medication. So we never come to know which drug is going to give you the reaction. So even if you have taken history that there is no drug reaction, still any new drug can develop the drug reaction. So these drug reactions are nothing wrong with your management. You need to pick them early. So they are always unexpected, unintended, and harmful event. So what is the alternative? Alternative is a careful medication history. There is no way you can miss the history, and in spite of that, still it can unexpectedly happen. Preventing the ADR depends on the avoiding the treatment in the patients. Like for example, when we are writing the medication, every time we should ask the question to ourselves, is it necessary? Sometimes we casually write down or prescribe so many drugs. We don't understand that these drugs are might not be helpful, but they might be harmful to the patient. So that's what we should do. Careful medical history, preventing your treatment cohort unnecessary for that patient. Now third is we have came across the adverse drug reaction. Now adverse drug event. Now, this was a 64-year-old lady admitted for the coronary angiography. She had a known case of diabetes, hypertension, ISD. She developed the near arrest after the injection SAPR exam. Now, it is a very casual or routine order for the all daycare procedures. They will advise the 1 dose of antibiotic. And there are so many times in hospitals, in wards, we are giving, or daycare, we are giving the 1 dose of antibiotic. But how many times we read that leaflet? How many times we take the history? How many times we are going through the detail about the patient? And this particular patient had a near arrest. He required the CPR. We resuscitated, intubated, ventilated, and shifted back to the ICU. And the relatives had the very one question: why this antibiotic was given? And this question was a very natural question, and the answer was, it is a routine practice. That's what we are telling. So adverse drug events can be adverse drug reaction. It can be overdose of the drug. It may be inappropriate drug. So adverse drug reaction is a one part, but the adverse drug events of the mix of all these things is the adverse drug events. So this will refer to as an injury resulting from the medical intervention related to the drug, including harm caused by the drug or uses of the drug. Now, when I gone to the leaflet of the SAFER exam, it was very clearly mentioned in the leaflet, and you please go through the leaflet. Test dose is must. How many times our doctors and sisters advise the stage dose in a daycare for the each and every drug which is bad. And you need to, even tomorrow, if the case goes in a medical legal this thing, it is very difficult to protect ourselves, because it is very clearly written test dose, and then we need to record it, we need to document it, the test dose was given. So this is related with the adverse drug event. These events are the worst than the adverse drug reaction, because it is not only they are comprehensive, they are significant, but the excess length of the stay, extra cost, and the mortality of the patient. For example, this patient, she came for the daycare routine diagnostic angiography. She spent 3 weeks in ICU, and then we shifted out of the ICU with the tracheostomy and vegetative condition, and then we sent him to the home. So what we achieved, and whether it was a preventable? Of course, it was a preventable. How we can prevent? Again, the medical history, go through the everything, whether it is necessary, not necessary, and follow the instructions for the drug manual, whether it was a test dose was given and everything. So adverse drug event is something like which is more one need to go into the detail, and they are made up of they are mix of the drug reaction plus overdose or inappropriate dose. We are very casual. Believe me, I'm working in a critical care area since more than 30 years, and we are facing this problem still after the even introduction of the AMR. Now, third category is the medication error. So we have gone through the adverse drug reaction. We have gone through the adverse drug events. Now, medication error. This patient was advised discharge. Discharge primary consultant on phone, say add tablet Cardiovas 3.125. On duty doctor written it as a tablet Cardiovas 31.25. And then primary physician received the call from the pharmacy. The dose of the Cardiovas is 3.125, but your doctor has written 31.25. What dose need to be followed? Here, the patient, we have able to prevent this medication error because of the pharmacovigilance. Pharmacies plays a major role in our medication error. Our medications in India are available at the counter. They are available very loosely without prescription. If the pharmacists are well trained, educated, and they are aware about the medication errors, they can prevent the majority of the medication error. Here, the pharmacist from our pharmacy was, of course, the well-trained pharmacist. So he understood that there is something wrong. Probably it was a prescription error. Doctor must have been written wrongly 31.25. But suppose that patient goes outside the hospital and take it from the over the counter because it is getting cheap, then probably he must have been landed with the taking the 10 tablets per daily. So here the issue is the how we can prevent it. So if we see the medication error, either they are a prescription error, or they are administration error, or they are transcription error, or they are dispensing. So every level you have to be have alert. And of course, the answer is in ICUs and in hospital, answer is EMR. So the chances of the typo error will be less and the spell check will be there. And that's why IMA as well as the government of India advise your prescription should be in a capital letters and in the with the generic. So avoid the company or the industry names on this thing because they will confuse. So write down the generic name. So your prescription, then transcription, whatever you are writing, somebody else is putting in another notice, then there are the transcription error. Then administration, you have your advice, prescribe it rightly, but transcribe it also rightly, but probably nurse has given it a delayed fashion or overdose or underdose or the wrong dose, whatever. So that is the administration error. And the dispensing means you prescribe it rightly, you transcribe it rightly, but your dispensing from the pharmacy was faulty. So it will be the dispensing. So there are 4 types of the error in a medication error, and we need to work on every stage, like what is the dose, what is the route, what is the documentation, wrong date, frequency. There are so many things. I came across the one of the article which is very rightly mentioned regarding the antibiotic stewardship. How many times the patients know their right to know about their prescription and doctor know what to do with the prescription? Like how many times patient ask whether this antibiotic is necessary, sir? What dose you have prescribed? Is it an overdose? Do you think it is an overdose? Does this drug has an adverse drug reaction? Please, if it is having the drug reaction, explain me in detail which are the reaction. How these drugs are stored properly? How many days it should be taken? Have you advised any investigation before prescribing me this medication? There are so many things patients can ask to their doctors and able to prevent the medication error. And that level of the education and training we need to develop in our society also, along with the doctors. So generally, medication errors are the 2 types. Already I told there are 4 types. There are another 2 types. Is either they are active errors or latent. Active means it's a interface between the human and the complex system. Like cath lab doctor advice from phone, then the junior doctor in the ward has written it, then they have put it in the computer system. It goes to the pharmacy, and then pharmacy has finally. So there is a complex system. Anywhere there is a chance of getting miss or there is a medication error. So what NABS tells us, it has to be the verbal orders should be repeatedly. So you have to say that drugs twice, which drug. And nowadays there is so much social telemedicine is available or telecommunication. You use the WhatsApp or the mails very smartly and the confirm whatever you are written is as per the order by the primary consultant. So there are so many active errors happen because of the humans and the complex system. And the latent errors are the hidden problems within the healthcare system, which we come to know later on. Some major events happen, then you go through the reporting, then you go through the root cause analysis, and then we find out that there are certain errors which are the preventable. So we need to understand the various types of the medication error, various categories of the medication error, and at what level we can prevent it. Now, the 4th type is medication misadventure. It is a mix of the adverse reaction. So, medical misadventure may be drug adverse reaction. It may be adverse drug events. It may be medication error. So, it is a mix and match of any of these 3 which results in the misadventures. Like this patient, This is the case of the COPD. She shifted to the critical care area with the hypotension. When we took the history, the ward sister has given a prazopress instead of prednisolone. And in due course, that patient deteriorated and this thing. So now here is there, we should not have a blame culture. Like the first thing we start blaming, the nurse is responsible. Nurse is responsible. She has given the wrong dose. The first thing, we need to develop the blame-free environment. Just develop the blame. There should not be blame. The blame should be go to the system. Who has advised the order? Who has written it? This thing, whether he has written it properly, whether it was readable. Have the nurse read that order properly? Have that it was transcribed to the pharmacy? Have the pharmacy properly cross-check? So entire system is at fault rather than that poor nurse who is always at the receiving end. So we need to find out the blame-free environment. So the medication misadvantages are generally at iatrogenic event. Like in this patient, there is either error, omission error, or commission error. There, somebody has bypassed the protocol. Somebody has not followed the policy. That resulted in the iatrogenic injury, and we landed with the very serious event. Medication errors these all adventures might be the medication errors or adverse reaction or adverse drug. So it is a bunch of the events, and they are always undesirable and unexpected. We never expect that, and this happens. So we have to be very careful. We have to follow the certain policies and protocol, and the most important in the checklist. In critical care area, we strongly believe in a checklist to prevent these misadventures. Now, the last part is a sentinel event. Sentinel events are always serious events. Like these two events, I will just quickly go through. My patient, this was few years back, advised lung biopsy lesion on the right side. But then during after CT, we thought it is posteriorly, so we asked him to do the prone, and we forgot to change the side. So what happened? It must have been the wrong side lung biopsy. This was a very interesting patient. These slides were shared by one of my colleagues. I will not disclose that hospital this thing. It was a 45-year male, came with the hoarseness, cough, breathlessness seen in by the SR in a OPD, did the ideal, which shows there is a lesion. So he advised the DL-scopy under GA. And when next day he done the DL-scopy, it was normal. So something was wrong somewhere. How can within one day the lesion is vanished? So nothing has happened. The day one, the patient and the day two patients were different. So there was a OPD, there was a full of the OPD and the daycare procedure. The name of the patients were same. So they must have been called the Jayanti Lal Sharma, Jayanti Lal Sharma, Jayanti Lal Sharma. Came inside, they did the procedures and it was, so probably the Jayanti Lal Sharma was a different. One with the lesion and one with the normal, this thing. So these are known as the sentinel events. Wrong person, wrong procedure, wrong site. Like my first lung biopsy was a wrong site surgery. This second example is a wrong person. Sometimes wrong procedures you are doing in. These are the sentinel events. These are the serious events, and these are the still one of the common factors by the Joint Commission of the accreditation in the healthcare organization. These medical errors can lead to the patient morbidity and the mortality and the outcome. Can you imagine? If suppose you do the lung biopsy on the normal lung, there will be pneumothorax, then there will be ICD, and there are so many other complications. And same the way with the other procedures. So we have to find out the solution on the system-based prevention. There should be the, like in this, I have shown already, we have to give the labels, right? This is the right side, right label, side, check the marker, confirm the name twice, confirm by the two persons. When you are, the excuse should not be that you are busy and your OPDs or OTs are overcrowded. Then the chances are more you are going for the sentinel event. So sentinel events need to be avoided. There is no way you can escape to the medical legal system, because there is no way you can explain the wrong person or the wrong procedure or the wrong site on any scientific background. And to finish with, we need to just go through our pharmacy and the storage look like this is a ampicillin and this is cefazolin, and the dose is also separate. This is a sulbactam, but this is a plain ciprofloxacin and this is ciprofloxacin sulbactam. But you need to check this. And most important thing, the doses like 10 milligram, 20 milligram, 30, 40 milligram, they are same. The chances of the medications errors are high. you need to give them the color coding, like the violet is 10 milligram, purple is 20, and something green is a 30. So you can, even looking at the color, you can say that this might be the 10 milligram or 30 milligram. And look at this. This is what the India. It's the worst part of our industry. Midazolam and pantoprazole both have same name, Medzol. So if you write down the Medzol and you are intended to give pantoprazole for the acidity, he landed with the midazolam, and then might be the respiratory arrest, and he may lose his life. So look at these common names. Look like Medzol 40 is a esomeprazole, and Medzol RD is a combination, and Medzol D is a pantoprazole, and Medzol 200 is a itraconazole, antifungal, where you can have so many Medzols in our system. So are you waiting for any tragedy? You need to check. It is also our responsibility as a hospital administrators, as well as the doctors and the nurses. And look at the look-alike. This is again the look-alike or sound-like, LASA. This is very common terminology doing this thing. Like one is a paralytic agent, one is a sedation, and one is an anticoagulation. 100% chance of the error. What we need to do? Just change their label color coding for this peak. Like your this color coding will give you this is sedation, this is heparin, this thing. This is very important. In ICUs, the color coding makes a lot of difference in terms of the patient safety. And that's what the photography can did the trick. If you see from the front side, if you see from the side, and that's what you can see on the your packaging also. The drug name and the dose should be same and will be visible and clearly visible from the all sides, and that is very important as any trick, photographic trick. So patient safety starts with us. We all are responsible for patient centric. It is not a one humans. We are going to error. We have to develop the system, error-free system. Don't cover up the any incidences. Please discuss with your team. Please report incident. Always develop the culture of the information. I always say that informed culture should be the culture. Every minor detail should be put it on incidents and reports, and just submit it to your authorities. And don't forget to learn, because from every incident we are learning. If we are not able to save one life, we can save the hundreds of the life by discussing and learning and finding out the solution. So patient safety should be the ultimate goal for our this thing. So to summarize my talk, patient safety is an important but the neglected aspect of the healthcare environment. Can be improved with the improving process of the care, not the individuals. Individuals still prone for the errors, but the system will be the less prone for. So improving the process for care is more important. Whole team should be geared up to the concept of safety rather than any one individual. And develop the reporting system and find out the problem and develop the safe culture in your ICU. And adopting the various bundles of the care can improve the patient safety. Like we have ETT bundle, we have the CVP bundle. There are so many bundles, we have bundles in ICUs and the critical care areas which help us to prevent the complication. Thank you. Thank you.
Good afternoon, everyone. Good afternoon, sir.
Good afternoon.
I'm Dr. Tanmay. I'm chairman of ICCIM Lucknow, sir.
Hi, Dr. Tanmay. Yeah.
I welcome you for this excellent talk and excellent CME. And it was a nice talk, deliberating all the aspects of the medication error and how it is happening, how to prevent it. I hope there must be some questions. Jui, is there any question in YouTube or in Zoom link? No. If there is none, I again thank you, sir. I'm coming to Best of Brussels, sir, with you, and welcome to Lucknow, sir, in Criticon in September 27 to 29. We are organizing on big conference here, sir.
Yeah, surely. And you are also welcome, and everyone is welcome to the Best of Brussels at the Pune, and it is one of the best symposium in the critical care area. And thanks, this was a good CME and a good talk. I always love to deliver such clinical but quality related talks, because we need to adopt the quality in our day-to-day practice. We cannot wash our hands as we are clinicians, and the quality is the job of the nursing and the other department. Doctors are equally responsible for the quality and the patient safety in day-to-day life. That's what I would like to say at the end. Thank you.
That's why the collaboration of ISCCM and Quality Cell SGPGI
Yes, yeah.
for the first time, and it is a very great success, sir. 600 plus people registered. Thank you, sir.
No, you should do it in a regular basis, and we'll be very happy to participate in future also. This is what the future, the last slide I should put it as a future, is a collaboration amongst the quality and like clinical pharmacists, microbiologists, pathologists, and nurses, and the doctors should be on a one dais to discuss the issues related with the patient safety. Thank you. Thank you, Dr. Tanmay.
There's one question.
So there is one question by Dr. Devendra Kumar Niranjan.
Yeah.
He's asked that why, if we on root cause analysis, when we find that it is the casual attitude of the nursing staff which is causing the medication errors, then how should we deal with it?
See, again, I am saying we should not now point out. Blame culture has to vanish. Okay, nurse is responsible. We need to find out whether it is a junior nurse or senior nurse. Second thing, why we are jumping that it's a casual attitude. Might be we need to see that which shift, whether she is overworked, whether she is doing the continuous duty, she has some issues. Third thing, whether she has a training about all these things, who is a supervisor, who is a senior associated with that. There are so many facets of the one error. So rather than saying that it's a casual attitude and just throw her out of the system is an easy solution for all problems, but this will not be the long-term solution. I need to develop the confidence amongst my staff that yes, we are prone for the errors, but please don't hide them. You come to us and we'll help you to sort it out. We'll not put you as a victim. And that's what I pointed very boldly, that blame game culture should not be in a culture. Casual, no, I never believes that any human being will do deliberate mistake. Like, why nurse will give a double dose or wrong dose deliberately with some intention? There must be something happen prior to. So root cause analysis should go to that prior event, that her attitude at the time, her thought process, her stress, her how many hours she is working, whether there is any replacement. There are so many issues with the staff. So I look at with this problem in a different way, rather than easy way is blaming her and throw her out of the system, because I need to even develop that confidence in my system that yes, we are with you. We are not here to just put everything on you and throw you out, because that message will go to the rest of my entire 700 staff.
Thank you, sir.
Thank you, sir.
So one incident I am remembering in my MD days, spinal analysis of bupivacaine and tranexamic acid vials are looking same.
Yeah.
So some of my junior already loaded tranexamic acid before giving it to spinal anesthesia. But one of the OT staff, he came in rescue and said, "Sir, you are taking wrong vial," and that saved the patient life, I can say. So
Yeah,
it's responsibility. It is responsibility of all who is involved in the process. Double checking, cross checking, pharmacovigilance. You have already discussed. These should be the important areas. Thank you, sir.
Thank you. Thank you.
We'll be interacting in November as well, and in November we are planning a second a big CME on this on quality management. In quality management week.
Yeah, surely. Thank you. Thank you, Tanmay.
With this, we now move forward, and ICU care is a complex landscape of patient care where every decision has profound impact on patient outcomes. So now let us explore this multidisciplinary approach and strategies for ICU care with our next expert, Dr. Tanmay Ghatak, sir. Sir, please.
Hello, good afternoon, everybody.
Good afternoon, sir.
So it's a full house. I'm seeing, great to see all our nursing in charges and staffs. And I'm getting information that more than 100 people have joined. It's a great honor to us as a first CME. It will encourage us for making more and more efforts. And importantly, I'll thank Jui Sister Ji, whose effort is enormous in this, making it very successful. Starting from the choosing of faculty, and what about the how about the whole program will be, about whom to invite, regarding pre and post test, everything she has done single-handedly. So again, congratulations to her. Next area of talk is very, very important. Being a nurse, you are close to patient. The doctor comes for 15-20 minutes. You are there for 6 to 8 hours. So it is very, very important for where the care of patient is concerned. It is purely your domain, mostly your domain. So my talk will more and more will be precise and helpful to you and your improvement. Because when you have it in your mind that these should be the areas where I can improve the patient's care, then you'll give that, you'll help the patient in getting that, and thus it will decrease the mortality and morbidity of the patient, and it will improve the patient outcome. Very easy. So what are that? We all know, as ICU is growing importance, Dulhan hai na, Dulhan. ICU is Dulhan of all institute. So ICU is growing everywhere, in every hospital. Being a small hospital, 10-bedded hospital, 4-bedded ICU. It will be like this, you know. Late 90s started booming. ICU care is started booming. Plenty of institutes having plenty of ICUs. In our SGPGIMS, there are 6 to 8 different ICUs, isn't it? There are several ICUs running simultaneously. You all, to some extent, to some period, worked in ICU, and some are really working now. So there are some areas you must take care of. Patient care in those areas, if you hit, it will improve patient care. It will improve patient morbidity, mortality. Definitely. So in my talk, what starts the discussion? When there is a booming of ICUs, some European started thinking what will be the best care, minimum care that we can provide, and that will improve patient outcome. Very easy. Some mnemonic must be there, so that we can do this, and that will improve the patient care, and that will improve the patient mortality, morbidity. That will decrease the mortality and morbidity. So here comes the article, and they compared the ICU staff, ICU physician, ICU technician, ICU nurse as a aviation cockpit. जैसे हम लोग विमान में चढ़ते हैं ना, वहां पे भी आपके हेल्प के लिए वो आते हैं, पायलट रहते हैं एंड अदर्स रहते हैं, जो सपोर्टिंग स्टाफ भी रहते हैं. एवरीवन इज टेकिंग केयर ऑफ योर सेफ्टी. हाउ it is similar to ICU because there is also complex system. उसमें भी कुछ alarm बज रहा है. There is also alarm, several alarms are going on, and your safety, your life is in their hand. है ना? This getting the point. So it is somehow similar to aviation cockpit. In ICU care, in any critical patient care is basically equivalent to that care, that situation where a pilot is running a plane, and some staffs are helping him out to save your life, to safely land you in your destination. That's the ultimate goal. So here also there is some complex machines like ventilator, some infusion pumps are going on, some alarms are already blinking, and obviously there is a life-threatening problem is every step. If he does any mistake, the pilot or any staff does any mistake, your life in aviation cockpit is in problem. Here also in ICU setting, your life is in their hand. But as a whole similarity, they are taking care of altitude, speed, some areas. But here in ICU nurse, ICU staff, ICU physician taking care of hundreds of things, like
Pressure agent, fluid challenge, fever control, blood transfusion, any sedation, any antibiotic, everything is in your mind. You are taking care of that in those few hours when you are with the patient, and you are taking advice from the physician, and you are doing it for the benefit of the patient, to improve the patient's morbidity, mortality, to decrease the mortality of the patient, and ultimately you have to make it improve and get rid of him from the ICU bed and improve him. These are all target. So there are some ICU care checklist. If you do this, if you maintain this in your ICU patient or in critically ill patient, there is definite help. There will be definite help for the patient, and you will do something better. Do not harm is the motto in ICU. Do not harm. Please, if you want, when you are not harming the patient, please help in this way so that the patient can be improved. This is simple mnemonic that is called first hug BD. हम लोग hug day मनाते हैं ना, chocolate day, hug day. तो ये hug आपको hug करना है daily. मतलब this and आपको first hug करना है, 2 बार करना है. जब आपको ड्यूटी आवर्स में आप डेली 2 बार hug करेंगे, that will improve the patient. What is that? F for feeding, A for analgesia. We'll be discussing in details in my next slide. F for feeding, A for analgesia, S for sedation, C for thromboprophylaxis, H for head of bed elevation, U for stress ulcer prophylaxis, G for glycemic control, S for spontaneous breathing trial, B for bowel regimen, I for indwelling catheter care, D for de-escalation of antibiotics. This is very simple. These are the tricks that you can improve the patient's mortality and morbidity. Very simple tricks. First hug BD. Daily आपको 2 बार patient को hug करना है. Easy है. इससे फायदा क्या होगा? What is the need? क्या यार डॉक्टर तन्मय is saying यार कोई भी आता है लेक्चर देके चला जाता है. We are not taking his advice. Please take these simple steps. These 10 steps will improve patient's recovery. It is very safe also for you, and it is increase the safety and efficacy for patient care, and it improves the quality of care. Here is a quality index when we'll see the quality index are based on these, some of these, that will improve your quality care in ICU. Very simple, and it encourages the teamwork. फलाना नर्स सिस्टर से बात नहीं करता, डॉक्टर तो आके कुछ भी बोलता है, फलाना डॉक्टर से लड़ाई है. नहीं, टीमवर्क. ICU is all, every critical care, everywhere it is teamwork. And if you maintain this only first activity 10 step, it will improve your teamwork. It will improve your care, quality of care. It will improve your safety and efficacy of patient care as well. Very simple 10 step. What are those? First, feeding. हम लोग 8 घंटा जब करके ड्यूटी से जाते हैं, क्या बोलते हैं, मम्मी खाना दो, या कि खाना कुछ बना, या खाना बनाना पड़ता है. तो हम लोग अगर 8 hours में we are feeling hungry, imagine of this patient who are 48 hours to 72 hours unfed by mouth, है ना, they're also hungry, and you are not feeding, as well as he is in critical illness, he is having septic shock, so there is having more and more negative nitrogen balance, and impair immune system. That ultimately leads to increased susceptibility to infection, more and more muscle loss, and bacterial growth into the GI tract. Ultimately, bacteria is invading into the body, and decrease wound healing, ultimately prolong ICU stay, more and more mortality, morbidity. Simple. So you have to feed him. But there is no marker. अरे कोई blood test करके ऐसा नहीं, you cannot say that he is malnourished. There are several parameters. I'll take in next slide. There are several parameters. The gold standard is saying there is an indirect calorimetry. There is a test. It is said that you can know somehow the malnutrition status, but it is very costly. It is difficult to perform, not practical to perform in ICU setup. So dictum is give feed. Which feed is important? Enteral feed. आपको नली से आटी डाल के या मुंह से आपको फीड देना है, आईवी से कम कोशिश करना है. एंटरल फीड इज प्रेफर्ड, क्योंकि हम लोग भी तो एंटरल खा रहे हैं. कौन सा हमें आईवी लगा के ग्लूकोज चल रहा है? नहीं चल रहा है ना. तो हम लोग भी खा रहे हैं, तो as normal as natural we are offering the patient as enteral feed, be it through RT feed or other methods, be it orally. Simple. There are two different scores. It is this nutrition assessment score, like nutrition risk scores 2002. There is one score, and there is another nutritional assessment in ICU score. There are two important scores. They are taking care of severity of disease. They are taking care of impaired nutritional status in view of weight loss. Last few days कितना weight loss हुआ? Last few days feed intake है कि नहीं? And age more than 70 years. जितना एज होगा 70 years की एज ज्यादा एज होगा, न्यूट्रिशन डिफिसिट ज्यादा होगा. So taking care of these three things, there is a new NRS score and there is another Nutrix score. This is taking care of a few score like Apache score, SOFA score, a bit difficult score. That is for nutritionist. They will take care of this score and they will say if it is more than 5, there is severely nutritional deficit. Please give feed in this patient immediately. Okay. Feeding, जो हम लोग 8 घंटे में जाके भूखा हो जाता है, तो the patient is unfed for 48 to 72 hours. So there is ultimate aim, ultimately he is in nutritional deficit state. So give food, give food, give food. Second thing, when the patient is intubated, when in our trachea, a simple respiration comes. What do we do? There is a cough reflex. Yes. थोड़ा सा भी खाने का टुकड़ा चला जाता है, क्या करते हैं? कफ रिफ्लेक्स करते हैं ना. क्योंकि इमेजिन a big tube, 6.5, 7.5 tube is inside his trachea. So patient is obviously coughing. Every time he is trying to cough it out. So there is a need for analgesia and sedation in those ventilator dependent patient in ICU. So there is a need for analgesia. Obviously, there are some scores. First score is there. Is having pain or no pain.
एक ही महीने में 5-6-7 खबरें आ रही.
Please mute. What are the problem with analgesia? If you give more and more fentanyl, more and more analgesics, there will be more and more long-term stay in ICU. Patient उठेगा नहीं ventilator से, उसको क्या पड़ा है सांस लेने का? You will not take this, मतलब the not natural normal respiration. You will be in your in bed bound. So there is so as long as important analgesia to be given, but analgesia is important for these patient, ventilator dependent patient. So for ACE, there is sedation. There is a need for sedation. I have discussed. His trachea is inside his the tube is inside his trachea. So there is a need for sedation. There is a sedation scale. Every doctor, ICU doctors, they're fond of this Richmond agitation sedation scale. This is done 0 to -5 to 4 scales, and the 0 scale is preferable. What about the problems? Yes, with more and more sedation, more and more respiratory depression, more and more prolonged stay in ICU, that will ultimately lead to more and more mortality, morbidity. Believe me, one thing, for T, thromboprophylaxis, we often forget this, because this is patient is lying, and the thromboprophylaxis, which is important. When the patient is lying, his leg is not moving, the more and more chance of venous stasis in his leg, and these venous stasis ultimately lead to venous thrombosis, and this venous thrombosis will lead to embolism in recent time, late phase of ICU stage. So it is one of the preventable cause of death. That thrombus will go into lung and ultimately cause pulmonary embolism. That is a preventable cause of death that you can prevent easily in ICU setup only by doing some chemical. आप unfractionated heparin दे दीजिए. You use low molecular heparin. We often forget. It is one of the preventable cause of death in ICU. In your hand, you can easily use the mechanical device. हम लोग in our ED setting, in our ICU, we use the mechanical pump for in the patient leg who is lying, or chemical device like unfractionated heparin or low molecular heparin. It is very important, and it is one of the preventable cause of death. Very effective, both the way, both mechanical and chemical. And it has some complication like bleeding complication when the patient is bleeding itself, we use it judiciously. When it is needed, it is used, we are using it. So it's one of the preventable cause of death. Next, first हो गया age. Head of bed elevation, 30 to 40 degree elevation of head of bed of the patient will prevent ventilator associated pneumonia, because more and more chance of aspiration when you lie down, when the patient is lying down flat, more and more chance of gastric feeding comes into esophagus and ultimately goes into trachea, isn't it? So more and more chance of aspiration pneumonia when the patient is lying flat. So please in ICU patient, please head of the bed must be elevated in 30 to 40 degree to prevent hospital acquired or ventilator acquired pneumonia. Next comes the ulcer prophylaxis. ICU patient is in under stressful condition. There is a chance of 15 to 20% patient is having stress bleed, stress ulcer. So you have to give ulcer prophylaxis in those patients. Every patient is in ICU. Every patient is having Rantac, ranitidine, or pantoprazole. You must have seen. Next, glycemic control. Very important. Often forget in your level. I have seen several times patient is having 200 plus sugar and nothing is going on. Nothing is you are not at least informed the medical person. Inform the resident that this patient having high blood sugar because patient is in having stress. When he is having stress, maybe he is having high blood sugar, hyperglycemia, maybe he is having decay or other complication, or maybe having hypoglycemia. So checking of blood sugar, it is in your hand. You often check and is just inform it that it is patient is having more than 200 blood sugar, and if some insulin or some hyperglycemic, oral hyperglycemic needed or not. Because more and more blood sugar, it will decrease the wound healing, more infection risk, ultimately leads to more and more mortality, morbidity. Next, come to spontaneous breathing trial. In ventilated patient, often in the morning hours, we decrease the sedation and we encourage spontaneous breathing of the patient to early extubation of the patient, early weaning of the patient, so that their stay in ICU will be less and we can weaning of extubate him off early. Next, bladder and bowel care. It is very important. आपको जस्ट क्या करना है, आपको जानना है कि patient is evacuated his bowel or what is the urine output of the patient in the last 24 hours. It is simple. If it is a patient is having constipation, it is also a bad situation. If patient is having diarrhea, that is also causing electrolyte loss and it will cause more and more harm. So definite good bowel habits is also important in ICU patient. Next, indwelling catheter, often forgotten as very important in your patient care. A patient is having peripheral cannula and for 15 days, patient is having thrombosis on it. Patient having painful injection. Please change it. Please inform. Central line, whole area is red. Please inform. Because catheter, the indwelling catheter care is very important because it's the hub of infection and it will create more and more hospital acquired infection. So please inform, please help to change. Until unless it is necessary, please remove it. Next, drug de-escalation. Often doctors also forget, we often forget, we are recognizing it, our fault. That patient is recovered from septic shock, sepsis, is having on meropenem, higher drugs, broad spectrum antibiotics. We often forget after 10 days, 12 days, every day we have to assess the patient if he is needing the drug, if he is improving, please decrease, de-escalate the drug so that when we'll be in ICU bed, all of us is going there. Please remember, in some time, we are also victim of some or any other disease. So if these drugs, they are limited. These drugs are limited. No antibiotics in pipeline last next 10 years. So what will you do if we are abusing antibiotic like this? There will be very limited antibiotic when you will be in that bed. No antibiotic will take care of you in that time. So please at least request doctor if he is improving septic shock gun, So please decrease the drug to minimum drug or no drug. That will be helpful for you, for us, for all patients. Next, very, very important. We often see this kind of two Nobel laureates. One is Nelson Mandela. Always seeing him in this picture. So these are two types of daily round. One, sab theek hai. One is like this. One is Teresa round. Teresa round is important, and Teresa round, Mother Teresa jante hai na? She is very careful of all the destitutes and others. And there is a Missionaries of Charity in Calcutta, where I am from. So this is it is my term. One is Mandela round, one is Teresa round. So please do a Teresa round whenever you are there in bedside. Please do it for patient care, for patient benefit. Okay. Next, very important ICU care approach is bundle approach. आजकल we are getting ना the mobile phone, the pen drive, the headphone, mobile case, सब एक उसमें bundle में मिल रहा है ना. तो ICU में भी ऐसे bundle है. The bundles are simple sets of evidence-based practice. When you are doing it simultaneously, it will improve patient care. Very simple. क्या क्या है? Corti bundle क्या है? When you are putting a urinary placing a urinary catheter, you have to take care of these 5-6 things, and it will help in patient care. क्या करेंगे? You have to perform hand hygiene. You have to wear sterile gloves. You have to insert single-use Dialocan. You have to use aseptic precaution. Simple as that. You have to put it in the catheter in the thigh. You have to secure it. You have to place it below the urinary bladder level. Very simple, very easy. And every time you are touching it, use unsterile, at least gloves you have to use. You have to wash hands. Simple. And every day reassess if he is reading it or not. If he is not needing it, remove. Simple. Next is, and in NABS, you all know, there is this calculation of rate of COTI. You all do, I think NABH we are doing, and these rates are important in your ICU, in your ward, everywhere. So it is important of total number of COTI versus total number of catheter days. Similarly, the central line associated bloodstream infection is having insertion bundle, having maintenance bundle. Mostly similar. You have to perform hand hygiene. You have to wear full drape. You have to full drape the patient as well. You have to full length sterile ultrasound probe and check the site. 2% Chlorox you have to use. Every day you have to check the area if it is soiled or not. You have to use a Tegadam dressing. 3M company is sponsoring us. So have to help them out as well. So you have to use that dressing, transparent dressing. You have to check it every day, and if it is soiled or not. And again, there is a calculation of like this: total number of Clapsy versus total number of central line days. Similarly, the ventilator associated pneumonia. These are also their checklist. You have to perform hand hygiene. You have to use sedation vacation. You have to go for 35 degree to 40 degree head elevation. You have to go for subglottic suction. You have to consider de-escalation of antibiotic every day, and use chlorhexidine in mouthwash. Again, there is a calculation of rate of VAP, where there is a total number of VAP versus total number of ventilator patients. Next, very important, often we see in our ICU, there are pressure ulcers. How it happens? There are some intrinsic extrinsic factors, like pressure, like moisture. Post-surgery patient is lying, restricted mobility is there, and these can cause damage. There is capillary problem, then tissue breakdown occurs. Thus, the pressure ulcer is occurring. There are several grades, 4 grades. We all know. I think questions with a pre-testament. There are several grades are there. Firstly, non-blanchable erythema in the skin, then the partial thickness of skin loss, then the full thickness skin loss, then the extensive destruction till bone. There are several risk assessment tools. That's a Barden scale, Norton scale. You can read it. And then the prevention of pressure ulcer. We all know that you have to educate the healthcare provider. You have to educate the patient family as well. You go for the identifies of the risk. You have to go for the effectiveness evaluation. You have to judge stage 1, stage 2, stage 4. If it is moist, you have to use another drug. When it is dry, use a cream. Next, very important, isolation practices. We use these to prevent the patient from the contact transmission, droplet transmission, airborne transmission. All of you know this due to COVID-19 outbreak. All of you, I think, know. जब हम लोग नमस्ते करते थे, कॉन्टैक्ट ट्रांसमिशन यूज प्रिवेंट करते थे, मास्क पहनते थे ना, मास्क पहनते थे कोविड में, तो ड्रॉपलेट एंड एयरबोर्न आप प्रिवेंट करते थे. कैसे हाउ द patient itself is transferring the organism. See this, the patient relative is sitting on her bed, and thus the patient who is having some infection may be transferring to the patient relative, or patient relative who is having some infection is transferring the infection to the patient, and someone is coming and someone is handshaking. See, is handshaking, and that it is transmission is bacterial transmission is there from the patient to the patient who is the patient relative who is touching, or the healthcare workers who is touching. So there are two types of barrier nursing. One is barrier nursing, one is reverse barrier nursing. The barrier nursing is for one isolation where the patient is infected. हमारे से patient आ जाता ना, MDR TB आ जाता ना, we have to isolate him. Why? The patient is infected. The patient is dangerous. You have to isolate yourself as well as the patient to get the to prevent the transmission of infection from the patient. And second term is the reverse barrier. What is that? Here, patient is not infected. You are infected. Here, patient is immunocompromised. Bone marrow transplant हुआ भाई. इसका अभी TLC 5,000 मतलब 500 है, 300 है. Here, the patient is immunocompromised. Patient is having cancer. The patient is have to protect the infection to the patient. So healthcare workers, you have to be very careful while touching the patient. Have to wash hand and then touch. Next, very important, IPC standard precautions. We often forget to hand wash. We often forget to. We often basically don't know about the waste segregation. We'll touch 1 or 2 slides on that. There are several germs in your hand, believe me. And there are several areas where you are touching unknowingly. These are the high touch area. सर ने बोला रे थोड़ा सा बीपी दबाओ, तुरंत जाके बीपी दबाते हैं. You have to wash your hand because it is high touch area. You often touch patient railing. That is a high touch area. Patient का chair तो छोड़ दीजिए, it is the highest touch area. Stethoscope, we often forget to clean it when we are changing the patient. एक पेशेंट देख लिया, हर एक पेशेंट को हमने बोलते हैं अरे इस पेशेंट को ऑस्कल्टेट किया, तुरंत चल के लग. Even doctors are often forget to clean the stethoscope hub as well. So there is a chance of more and more cross infection due to us. We are responsible for MRSA to the near. अब कई बार सुने ना MRSA आउटब्रेक हो गया, एक पेशेंट का MRSA था, नेक्स्ट पेशेंट को भी MRSA, देखो क्या पता नहीं क्या वो कैसे हो गया. It is you, me. We are doing it. We are transmitting the cross infection because of us. The second patient who is having another disease getting MRSA, and it is totally preventable. Believe me. So 5 moments of hand hygiene. सुबह से कई बार बोल चुका होंगे. Before touching the patient, before any clean procedure, after body fluid exposure, after touching the patient, after touching patient surrounding, you have to wash hand. You have to perform hand hygiene. हम लोग सब जानते हैं palm to palm, palm to back, fingers, finger interlock, thumb, सब जानते हैं बट करते नहीं. प्लीज इसको हम लोग बहुत इजीली कर सकते हैं. 52 सेकेंड्स लगते हैं. जनगण मन गाइए और इसको करिए. मैं तो बोलता हूँ ये मेरा टोटका है. प्लीज डू इट while washing hand. You are standing, you can in your mind you can sing and you can do. 52 seconds लगता है. You know 90 times it is improper. We are washing hand, but it is when the surveillance culture you have seen several times surveillance culture, and you have seen the 90 to 95% time it is improper hand washing. आपके पास क्या जुक्ति होता है? जानते हैं? Other colleagues are not doing hand hygiene. Why? My hands are not dirty. I am sterile. Yes, but study result है. 2019 study result. See what there's your what everyone is saying. Patients get offended. Why? ऐसे भी आया है. It is not important for every patient. See, there are the reasons for not practicing hand hygiene. Next, biomedical waste management. We all know. वो येलो बैग में क्या डालते हैं? जो ब्लड स्टेन होता है ना, ब्लड स्टेन. रेड में क्या डालते हैं? रेड इज नॉट फॉर रेड, रेड इज फॉर प्लास्टिक. नीडल और मेटेलिक सब किस में डालते हैं? पंक्चर प्रूफ कंटेनर में. एंड ग्लास में क्या, ग्लास किस में डालते हैं? जो ब्लू कंटेनर होता है. वेरी इंपॉर्टेंट एरिया. Jirpe sir already mentioned in his speech. Often we do mistake because 2R is human. We have to cross check several times before giving medication. Calcium bola ki potassium bola, we have to cross check several times. So take home message is very simple. My very 2 cent is take care of several small things that can improve patient outcome. Basic ICU care and bundle approach is a must for betterment of patient. Infection prevention and control is the backbone. IPC I have already touched. And washing of hand can save life. If you wash your hand, it can save others' life. So it is a take ICU message for today for my talk. If you improve by 1% after this talk, I will think it's my credit. Thank you. We are organizing a good conference in September. There is a nursing workshop as well. You can join the big conference in SGPGI itself. Thank you.
Thank you so much, sir. We have 3 questions.
Yes, yes. I'm happy to answer.
The first question is, what should be the target blood sugar for patients on ventilator?
Yes, the target blood sugar, please remember, is 180 to 200. There are several studies. First study came, initially they are saying the tight control is important. 80 to 110 is our target. But ultimately, there is a big study came, 5,000 on 5,000 patient, nice sugar control in 2008. So that if you getting patient blood sugar, if you are managing by 180 to 200, it is very good. Believe me.
The second question is that can we use long-acting insulin in an ICU patient?
Yes, you can use a long-acting insulin. Now, what is the goal? Initially, what we are doing? It is increased blood sugar. We are pumping some subcutaneous insulin or IV insulin. No. Now the concept is glucose variability. अभी 400 है, अभी 50 हो जाएगा. It is bad and dangerous for the patient. Believe me. So long-acting insulin, what it is doing? It is slowly controlling the blood sugar. Nowadays, you must have seen IV insulin is the therapy. Then the subcut insulin, what we are preferring initial days. Now, post 2022, there are several studies that the glucose variability is dangerous. अभी 400 है, आपने कुछ push कर दिया, चला गया 50. That is dangerous. That is very dangerous. So our target hourly decrease by 10%. 450 है, 440 करो, मतलब decrease by 340, 360, like this. Don't jump to make it 200 like this. So per hour, per few hours, you have to decrease it by 10% only. Believe me, that will improve patient outcome better. Yes, third question.
Sir, please shed some light regarding the urine collection from silicone cath in ICU.
Silicone cath, nowadays it is important. It is a long-term, it can be used as a long-term care. Like 21 days to 30 days, you can put the silicone catheter. When discharging a patient, a bedridden patient, head injury patient है, मान लो टेकोस्टोमाइज पेशेंट है, लॉन्ग टर्म केयर चाहिए, जिसमें आपका आईसीयू में अब केयर नहीं चाहिए, उसको होम केयर से मैनेज हो जाएगा. Then you can use this silicone catheter and forget for 21 days. Then you can change. Very nice to interact you. We are promising again, we will be doing this kind of workshop in November. And please join in our Criticon. There is a nursing workshop, very good nursing workshop. national faculties are coming. It will be good workshop. Thank you.
Thank you much for your time, sir.
Thank you,
so
sir.
much. Thank you, sir. With I now invite Mrs. Joyita Ghosh to present sir with a token of appreciation.
regarding there is one question regarding how to prevent ventilator associated pneumonia in an intubated patient. So I've already discussed it. Have to, and it is not community occurred pneumonia when it is patient is ventilated. Once ventilated, the pneumonia is called ventilator associated pneumonia. Simple, very simple. And how to prevent it? To some extent you can prevent, like head elevation, sedation vacation, and hygiene. These are the important steps prevent this ventilator associated pneumonia in ICU patient. Any other question?
No, sir. So we'll now begin with our last session for the day on the topic of prevention of central line associated bloodstream infections, that is Clapsy, recent recommendations and guidelines. And this will be taken by our expert, Dr. Ashmita Paul ma'am, who will emphasize on this topic vis-a-vis rigorous aseptic techniques and continuous quality improvement. Ma'am, please.
Good afternoon, everyone. I believe my voice is audible. So I'm Dr. Ashmita Paul. I'm the 3M clinical specialist, and I would at the foremost like to thank the organizer, especially Tanmoy sir, to give us this opportunity. So as mentioned, the topic is on preventing Clapsy. So the first question that comes to us, what is the current situation? Do we know about Clapsy? Like what exactly is the burden of Clapsy? So Clapsy being central line associated bloodstream infection is unfortunately still an infection which is very prevalent in areas like, countries like India. So if you look at this worldwide map, we can, see that the burden of various HAIs are still quite in higher range in the countries like India. So what we can say from is this, that there is still no miles to go before we can sleep on this. So hospital-acquired infections, including Clapsy, is something we are still focusing on. We still have a way to go. We still have some distance to cover before we can say that we are at par with the other leading nations of the world. So this was a study which was done in around 40 hospitals from 20 cities in India. So these were, few studies which were multi-centric studies. So there they actually could clearly show that in an Indian scenario, wherever in an ICU there are patients with Clapsy, the mortality increases many times, almost four times, and the length of stay also increases from a average 4 to 6 days to 14 days. So this data actually shows us the actual effect of Clapsy, which we already know that Clapsy is an infection which is not only difficult to treat, but also is life-taking. So it has a very high mortality. In fact, worldwide, it has been seen that 1 in 4 patients who contract Clapsy do not survive that infection. So and even if they survive that infection, there is a increased hospitalization which is associated with this infection, which brings us to the next point, that what can we do about it? So the good news which I would really want to share is that over a period of time, it has been seen that we have not only identified Clapsy as one of the major infection control goals, but over the period of time, say since 2001, the number of Clapsies have also decreased. So this has been because of the hospitals, the awareness, their commitment to following bundles and various other efforts by the entire team, including doctors, nurses, technicians, which has led to an overall decrease in Clapsy across hospitals in India. But again, there is a long way to go. Even now, if you look at the Indian data, the healthcare associated infections, they are lying somewhere between 14-15% to almost 60%. So this is what the Indian scenario is, and we still have to continue our efforts. So for understanding Clapsy everywhere, we have to first understand what are the major source. So the potential source which has been found, which is responsible for the major source of bacteria or microorganisms, has been the skin, and followed by the interluminal contamination, that is through the hub. So these are the major sources of infection. Other sources of infection also coexist, but this has been seen to be the major. And these are the, bacteria or the microorganisms responsible for most of the Clapsies across India. So, and of course, we can very well see from this, many of these are antimicrobial resistant. So this is the pathogenesis of CRBSI as we know it. So this, I think most of us are aware of it. So I just thought I will also, have a, quick glance at it. So now coming back to the topic. So what can we do about? What does the guidelines and recommendations say about it? So we are going to look at certain guidelines which are well accepted across hospitals across the world. So right from CDC, INIC, ISCCM, so they have their own guidelines, own recommendations regarding prevention of Clapsy. So today we will try to go through these recommendations as as much as we can, and we'll try to see what are the major points. And one thing that we'll always see is that most of the guidelines, they talk about certain points which are very much common across these guidelines. So this is one CDC bundle, which we also like to call as a CRBSI bundle. Now, this bundle was it was published way back in 2005 by IHI. Later on, CDC adopted it. And, I think this bundle is familiar to many of us. So this is what we call also as a Clapsy bundle or a central line bundle. And these are the core components of the bundle. So hand hygiene, maximal barrier precaution, chlorhexidine skin antisepsis, optimal catheter site selection, daily review of line. So now today we are going to go through, since we are all here in the conference by ISCCM. So we will be looking at some of the ISCCM guidelines. What do they talk about? Central line management. So number one is catheter selection. So they're very clear when they say that the catheters with minimal lumen, should be taken up whenever possible. But we know this may not be the case always. There are reasons when a doctor goes for a multi-lumen catheters. But having said that, catheter with lesser lumens will be more suitable when it comes from an infection control point of view. Hygiene practices. Now, already sir has said, and Dr. Ghatak, he had very well emphasized on the importance. I'm not going to repeat myself, but what I would like to note here is that hand hygiene compliance is an condition which has been, there for a long, long time. We all know the importance of hand hygiene, but even then, the compliance always varies. So there can be various reasons behind it, but the best would be if we can, bring up our compliance to the required level. So it still continues to be a challenge, but as I already mentioned, things are improving, and one day probably we'll reach our goal. Similarly, maximal barrier precaution. Now, again, all the checklists, be it CDC, be it the guidelines by ISCCM, they talk about following maximal barrier precautions. But is it being followed in most of the hospitals? The answer is variable. Some follow, some do not. So the reason behind is many. And interestingly, one study has shown that it is not always the cost constraint or the resource constraint which leads to non-compliance. At times, it is the lack of motivation, even, which also has led to lower compliance. So again, this is something we can very well have a hard look at, that why don't we follow the precautions which are mandatory when it comes to a central line insertion. Similarly, skin preparation. Now, this skin preparation recommendation, be it by WHO, CDC, all of them come to same consensus that we will continue to use chlorhexidine and alcohol combination for skin preparation whenever we are looking at any invasive procedure, not only central line, but for peripheral lines, but for surgical incision. But again, there is always a mix of response. Even now, we know in some of the hospitals, they still prefer, or some of the clinicians, they still prefer using betadine, or let me put it as providine iodine. But again, WHO very clearly mentions that use of providine iodine should be only be restricted in those cases where the patient is allergic to chlorhexidine. But other than that, each and every place we should be using chlorhexidine and alcohol combination. This is widely available now. Most of the hospitals have started this practice, and we really hope for a full house conversion very soon. Central venous catheter site selection. I believe everyone of us are aware of this, that among the 3 sites which are commonly, considered for central line insertion, femoral site is the one which is, affected with the highest risk of infection. So again, the direction comes very simple by CDC, by ISCCM, that avoid the femoral vein. What next to consider? The subclavian or the internal jugular, but not the femoral vein. So again, catheter site selection also has a very important role when it comes to prevention of Clapsy. Central line fixation. Now, again, many hospitals are using skin sutures, but we know they come with their own risk. So again, though there is no such recommendation that whether suturing should completely be avoided or not, but then there can be some antimicrobial, solutions that we can adopt, which will reduce our risk of skin contamination. So coming to the dressing, which we will use to cover the central line. Now, these are the various organizations which are giving their own recommendations when it comes to central line dressings. We are going to look at the bundles, which also talk about the insertion bundle. So here also, they're talking again the same points: the hand hygiene, the skin antisepsis using chlorhexidine in alcohol solution, maximal sterile barrier precaution, and avoiding the femoral line. So this is in a nutshell a summary of the insertion bundle, which these guidelines talk about. Now, coming to the dressing part, this is the latest update. CDC since 2017 has been talking about replacing our normal sterile transparent dressing with a chlorhexidine based dressing. Now, this has been supported by other guidelines like SHIA since 2023, again by INS. So they also believe that use of a chlorhexidine impregnated dressing will definitely reduce the risk of Clapsy in patients across the hospital. But of course, right now, the strongest recommendation is for patients above 18 years. So coming to the maintenance part. So this has been a topic, even I have, wherever I had gotten chance to interact, I have always maintained that insertion bundle is followed more closely than the maintenance. So once the central line is in, maintenance becomes a responsibility of the entire ICU care team. So here again, we need to make sure that we are following the bundles of the recommendations are. Like assess the need for catheter daily. Now this is very important. Once the catheter is in place, assessment of need should be done every day at least once, whether the doctor or the clinician thinks that there is a need to continue with the line or not. If not, it should be removed as soon as possible. Similarly, hand hygiene before manipulation of the IV system. Again, something unfortunately has been observed to be not so compliant. So at times we forget to use the hand rub before even just touching the cannula because we think it's not so important. But again, that is something which needs to be avoided. Chlorhexidine impregnated dressing to be used as many times we can. IV administration sets or secondary sets also should be changed as per the hospital protocol. Disinfecting the IV access port with appropriate disinfection for a period of time is also very important when it comes to the maintenance bundle. So maintenance bundle basically talks about how do we continue taking care of the central line so as not to introduce the infection later on. As we very well know that intraluminal contaminations occur later part of the central line life cycle. So it is very important that we do take care as long as the central line is there in place. So ISCCM also talks about use of prophylactic antibiotics and antiseptics and their role. They strongly recommend the use of chlorhexidine dressings. They strongly recommend the daily chlorhexidine bed bath or sponging as whichever is possible for patients in ICU to reduce this kind of incidences. This suggests the use of antibiotic lock solution. This is not highly recommended, but it can be used in limited conditions or situation as it requires. But they do not talk about any systemic intravenous antibiotic just for the purpose of prevention of Clapsy. So CVC catheterization, we know it not only occurs inside ICU, but at times in emergency wards also, at times in OTs also. But wherever it is there, we should maintain all the aseptic conditions and the bundles should be completely followed. And this requires a strong implementation of the SOPs. So this is just a kind of an example of a procedure safety checklist. I believe most of the hospitals, they have their own checks in place, which would be based on these guidelines. So coming to the port utilization and maintenance, adequate hub disinfection is again another challenge which most of the hospitals are facing. The reason behind it, this is again little dependent on the staffs and their motivation factors. So though most of the hospitals have a protocol of scrubbing the hub, but what is the compliance is always something that they are worried about. So for scrubbing the hub, there are two ways they can do it. One is, of course, active disinfection, which is scrubbing the hub for 15 seconds and 15 seconds to dry. Another is using disinfectant caps, which already have alcohol impregnated sponge inside, which takes lesser time to disinfect and unless removed can disinfect the ports up to 7 days. So the hospital has a choice. The guidelines will support both the options. So hospital can take an individual call which of this a system suits them most. But the point which is of importance is scrubbing the hub must be done either with an alcohol swab or you can go ahead and use caps. So disinfecting hubs or caps, these are the best practice guidelines by JCI, CDC, INS, and IACCM guidelines also talk about the same. So we must choose our option and we must train people to make sure that scrubbing the hub is always done. So prevention of mechanical complications. This again, there is a role of sonography, guide wire exchange. So IACCM have their own statements on it. Similarly for tip positioning also, they're recommending the use of chest X-ray, which probably almost 100% time it is done. So they have their own, conversation on education, training, and audits. So this is again very important because all the tertiary institutes and most of the hospitals these days, they have their own bundles in place. They have their own checklist. Whether they're getting implemented at the ground level is the question they must ask themselves. So for this, regular education, training, and regular audits must be followed. This will only help, the compliance part. So this is very, very important and we must work as a team, the clinicians, the infection control team, the quality team, the admin team, they all must work together to make sure that the bundles are in place, they are implemented and to make sure that they are being done in the ground level where it actually matters. So with this, I would come to my session. So the takeaway message, which I would really like everyone of us, one bridge in this entire process could impact the patient lives. So at times we look at the bigger picture, but it's the smaller points. But unfortunately, life isn't that easy. So whenever we are dealing with a central land and we're trying our best to prevent Clapsy, we need to make sure that the entire bundle is covered and followed. Not just, something that suits the organization. So the bundles must be followed rigorously. But the checklist may or may vary from hospitals to hospital. So that is all. I wanted to really convey the message in a very short time, I believe. So thank you for your time and patience. If there are any questions, I would like to take them.
Yes, ma'am. There are two questions.
Yes.
Someone has asked how much contact time should be maintained while using 2% chlorhexidine gluconate with 70% alcohol.
Yes. So thank you. Again, I would really thank you for this question because I think this is a knowledge which should be there with everyone. So when the WHO recommends if you're using a solution of 2% with 70% alcohol, if the sites are dry sites like probably the subclavian or the internal jugular, the skin prep time recommended is minimum 30 seconds followed by time taken to dry. So this is the recommendation by WHO, which is also taken up by CDC. But if the sites are wet sites, like the groin area, we're talking about a femoral vein line here. In those cases, the skin prep time increases. So it should be more than 1 to 2 minutes in those cases, followed by adequate time to dry the skin. And while drying the skin, nobody should be using any other method like blowing air or anything. It should dry naturally.
Ma'am, the other question is, in case of Clapsy, which one is more important, insertion bundle or maintenance bundle?
Very honestly, from both the bundles are equally important. That's why they are bundles. Bundles means mandatory practices. But if you're talking about the compliance, mostly the maintenance to suffer more. The reason behind is we become complacent as the central line is there for a long period of time. And the daily work, the daily workload and everything makes us little bit more, maybe let me not put it this way, but maybe we become complacent is the word I would like to use. So both the bundles are equally important, but I believe the maintenance bundle needs more implementation.
Yes.
So thank you for your time. Have a great day, everyone.
With this, we have concluded all the sessions for our first day, and we now move forward towards the vote of thanks.
I extend my heartfelt thanks to our distinguished speakers, dedicated organizers, and engaged participants for making the day one of this webinar a resounding success. Your insights and expertise have provided invaluable perspectives on improving healthcare facility quality. Special thanks to our technical team for ensuring a seamless experience. Your collective efforts and commitment to enhancing healthcare standards are deeply appreciated. Together, we are shaping a brighter future for healthcare workers and patients alike. Thank you for your time, dedication, and contributions. Let's continue striving for excellence in healthcare. Thank you, everyone.
Thank you so much.
Join again tomorrow.
Tomorrow we'll be starting 9 a.m. sharp.
Yes, sir. Sure.
Thank you. Thank you. Thank you, sir.
Yes, we conclude our day one, and tomorrow we start at 9 a.m. sharp. Thank you so much.
लैब लाइटिंग कल तो होगी नहीं, इसलिए वो लेके जाना। ये भी है ना, फोल्डर भी है ना, तो आप ले जाइए। ये दोनों सोनी जी को दे दीजिए, ठीक है। वो किसका? वो एक्स्ट्रा है। ये ये